Hello everyone. Very warm welcome. You have joined us. Today, our session theme is that we will take your one SPT, one long case, and one ST. And Dr. Saba is with us. And here is a short introduction of Dr. Saba. She is my FCPS student, but rather I will say no, FCPS consultant. And she has also actually take very good score in her MRCPI written and OSCE exam as well. So I would like that Dr. Saba will start today's session. How are you, Saba?
I'm good, Dr. Hera. How are you?
I'm also fine. So are you comfortable if you want to start?
Yes. Let's start.
Oh, okay.
Assalamu alaikum. Good afternoon, everyone, and welcome to our MRCPI OSCE preparation session. I'm truly delighted to have all of you here with us today. I have been in your place once. The long nights, the uncertainty, that burning desire to crack your exam in one go. I have been through all these stages. As Dr. Hera told, my name is Dr. Saba. I have done MRCPI written and OSCE exam with top scores, and I hold fellowship in Gynae Obs as well. So today I want to make sure you don't just pass, you excel. Our goal today is not only to learn how to approach the exam, but how to think, act, and communicate like an MRCPI consultant. It's not the matter of knowledge, it's your body language. But I think MRCPI for me is a gateway. You enter in the morning in the examination hall, you are a candidate. But the moment you leave your examination hall, you have proven yourself that you will come into this group of consultants. And you prove yourself that the president of MRCPI, he rewards you this degree on conferring ceremony. Our goal is to help you prepare in such a way that examiner should don't have any choice. We will make you practice so strong that they are almost forced to give you top scores, inshallah. By the end of the session, you will be mastering the exam format, what the examiner is looking for, how to compose yourself in difficult or unknown cases, and how to crack this exam in one go. Uh, Trust me, the examiners are there to pass you. They are looking for a reason to do so. So they want to say, yes, this candidate is ready for independent practice, and this girl belong to consultant room. Are you ready for this? Let me open some.
Yes, ma'am. We all are ready and motivated.
Okay, ma'am.
I came back, ma'am. Finish my prayer.
What do you said? I couldn't understand.
Ma'am, I came back. I came back, ma'am.
Okay. Welcome. Okay, so we will discuss the course structure and examiner's expectations. We will do it one by one. As most of you already have done your written exam, you are just one step away. So this one step, the MRCPI OSCE, should be in such a way that you don't feel nervous on the examination day. So let's understand the format of the exam. We have two types of station, circuit station and long cases. In the long case, this is a cubicle. They designed the examination hall that you have a cubicle. Cubicle means like a small room. You enter your cubicle in here. Outside the examination hall, they give you a paper. On that paper, there are stickers. What do you mean by stickers? Your name, your roll number, your MR number, or whatever examination roll number. It is pasted on those stickers. Why they do so? So that while writing your name and roll number, the examiner should not make an error. So they give you stickers to be safe side. The moment you enter in your cubicle, here, this is you. These are your two examiners and the one patient either sitting on the right side or the left side. In this cubicle, the long case is designed in such a way that they have the two examiner. Examiner 1 have the history and examination. Examiner 2 usually have investigations and management. But they can like shift on into this format. It's not the hard and fixed. Other thing is that important to notice, they have 24 or 25 minutes for this long case. So I would recommend you to divide and practice in such a way that for examiner 1, you have 12 minutes and you keep your other 12 minutes for examiner 2. For at the end, you should be spared like 1 or 2 minutes. Like for this long case, try to finish your long case 1 or 2 minutes earlier so that if you left anything, usually examiner, they say you want to add anything, try to reach at that stage like you are left with 1 or 2 minutes extra. We will do that, don't worry. The other station is circuit. What do you mean by circuit? Circuit is what we say like short cases. In the circuit, we have two type of station. Simulated patient task, we say SPT, and the structure discussion. In SPT, in long case, how many persons are in the cubicle? 4. But for the SPT, we have 3 persons sitting in the cubicle. There is an examiner, a patient, and this is you. In the structure discussion, here is the examiner, here is the candidate, and only 2 persons will all in structure discussion, 1 examiner sitting. Most important point to note, all ears towards me, please, please, please. This is the difference. If you learn at this stage, you will master your SPT and structure discussion. For simulated patient task, the patient has the questionnaire. The patient has to ask certain questions. You will answer those questions. You will talk with the patient. This examiner will be silent during your SPT. She won't say a single word. She won't ask anything from you. The structured discussion, the examiner has the questionnaire. You have to answer the questions of this examiner. Here, examiner will just mark you. You and patient will communicate with each other. Am I clear so far? Is it clear?
Yes.
And there is the one rest station, girls. There is the one rest station. In this station, obviously only you will be here. This is the station in which you will compose yourself. So usually structures are like 6 and 1 SPT and 1 rest station. There is the cubicle lines. You stand in front of the cubicle. It's not about like you will enter cubicle 1 or cubicle 2. They will make you stand randomly. Randomly, you enter in your cubicle. Your first station can be rest station. Your first station can be SPT, can be SD. Any station can come in your way when you do your circuits. And they usually do the circuits together, long case in the morning or in the evening. Everyone of you will be having one long case, either gynec, either obstetric long case. It's your luck. It's random division. And in the circuit, these stations you have, and all of the candidates have go through this circuit. This circuit will remain same for everyone. But for me, if I have done the gynec patient in the long case, next candidate will do the obstetric. You understand this way? Okay, so this is a real story, by the way. This is a story of my friend. So what's going on here? Anyone? What's going on this story? This is Miss Lena Jones. She is librarian in Australia. She is 24 years. She has problem with her periods for which she went to the GP. GP wrote an ultrasound for her, and she is here in the clinic with you with that ultrasound report. And on ultrasound, there is an impression of the fibroid. Say, for example, very small fibroid, 3 into 4 centimeter. What's going on here? This is our excited MRCPI candidate who knew all the guidelines of the fibroid, all the talk articles, EBM, every book. She is expert in fibroid. The moment patient enters, she is excited. She said, oh, fibroid. I read this yesterday. She started telling the patient it is a benign It is a benign condition. This is made of smooth muscular cell. On histopathology, it looks like that. The position can be on fallopian tube. Its location can be intramyometrial, whatever. Whatever she remembers about the fibroid, she is telling, and the patient is shocked. Her sister, which was here in the clinic with her, she is also shocked. The moment our pretty doctor, after dumping all the guideline to this patient, the patient is sad because what she remembered, oh my God, I have a tumor. I have a tumor. Because this is a benign tumor, truly in the medical sense, the doctor is right. But the patient is sad. She was not explained in simple language. The doctor has beautiful long nails. She asked her to lay down and she is pressing on her tummy. Oops, patient leaks. Doctor said, we will treat you as myomectomy. We will do your myomectomy in general anesthesia. Patient immediately runs out of the door. And she's leaking on the floor. What's going on? What's wrong with this doctor and this patient? Anyone? What's wrong in this story? The doctor is right. Diagnosis is very right.
You have to use simple
Even she
language.
over-explained her. What's going on?
You have to use simple language.
Number one,
And we have to follow up with the patient if she's following the pace or not, and involve the patient into the discussion.
and what about this third part?
This third part.
Examination. Did she
What
ask
was
her
wrong
to
with
empty
it?
her bladder?
Okay, maybe, yeah.
No. I don't want any of you to be this MRCPI candidate. I want your patient should enter in your cubicle with the smiling attitude, with the hope that her GP told this doctor will explain you your disease diagnosis and she will provide you the best possible treatment. Your patient should be smiling. Her sister or whatever comes in way, that person should be smiling. They should have a rapport and confidence. They should be sure that you are a safe doctor, simple language, and they understand their disease well. You examine them perfectly in maintaining their privacy, asking them to empty the bladder, like following all the protocols of the examination. And the patient should go home. While driving her car, she should be thinking about you happily, not just running away from you. So, how to be that ideal candidate, that ideal consultant, we will discuss that in a while. Guys, what is this? What is this? Do you know the term iceberg? What does it mean by iceberg? Any of you? This is basic science, by the way. I'm not doing any fancy things. You know what is iceberg? Any of you? Have you experienced the cruise travel or the ocean? Any of you?
It means that what you are seeing is just a little bit of what it actually is.
Yeah.
Tip of the iceberg.
Iceberg is like this is the part you show to your examiner. This is your knowledge and core which you take inside home. After your examination day, you drive your car and you remember, oh my God, I forgot to tell my examiner this. You take shower and you remember, oh my God, I didn't told her this. I knew that. Why this regret is here? Because you practice only this much. You speak only this much. In front of the examiner, make sure you present yourself very well and this should be flip on. If you knew this much, tell your examiner this much. This much should be forgotten, that's fine. But it should not be in this way you didn't speak in front of your examiner. The reason is that lack of practice. Trust me, OSCE, Dr. Hira gonna scold me later, but I'm telling you truth. OSCE is just 50% of your knowledge. 50% is your practice, your rehearsal, your attire, tone, composition, acting, and communication like a consultant. It's just 50% of your knowledge. It's not a memory test at all. Trust me, memory test was MRCPI written exam. Whoever remembers guideline will pass that exam. That was your memory test. This is not your memory test. This is test of your nerves and your performance. Okay, this is all eyes towards me. Now, everyone, I want you to pause for a moment. Really focus here because this is the slide. This is your bread and butter for this OSCE. Trust me. Your patient is standing under this tree. There is a disease or a disaster. Say, for example, rainfall comes in the way. The patient, you have to save your patient. You have to save it from any calamity. What you do, you try to build a nice room for your patient. This room containing the four walls, that is your history. If you built your history very well, you did a major part. After that, the roof is your examination. Relevant to that patient, the roof is your examination and the door are your investigation. Now tell me, you made everyone in your house, every room has a door and the door is fit for this room. Did you apply the garage gate here? Can somebody put on every gate of house on this picture or in this room? No. So why you ask every investigation from your patient? Why not relevant to this case only? Coming to the fourth part, the management. The management is just a window. For MRCPI, you enter at the registrar level. There are consultants, there are seniors, there are professors sitting behind you. What you'll have to do, you have to take the history, do examination, order some investigation, make your patient prepare, and tell her what's the procedure is going on or how you're going to treat that patient. It's not about doing your surgeries. The management plays very minimal role. Am I clear so far? Am I clear, guys? So
Yes,
if
doctor.
you ask me, if you ask me, there is one slide I want you to remember from this discussion today. This is that slide. Everyone, please pay very close attention. This is the key slide of today's discussion. If you have built your room wall so perfectly, any case, unknown case, tuberculosis, epileptic case, you didn't prepare for cyst, you didn't prepare, you forget to revise your fibroid case, any case comes in your way, this is your protective shield. This slide is your protective shield. What if I tell you I made window very beautiful, the door was perfect, the roof was little bit okay, but I forgot to make four walls. I only make, say for example, one wall. Is it a safe room? No, not at all. We need four walls, roof, door can be missed. It's okay, fine. We can dig out the patient from the room. It's okay. Window can be missed. It's okay. It's okay. Okay, what happened to me when I entered in the cubicle? I did all the like history taking. My examiner, the case was new for me. I was thinking this is an ectopic pregnancy. I was thinking the case is like ectopic. I was the pain. The patient has the pain, abdominal pain. I was thinking it's an ectopic pregnancy. I took the history in a perfection. I did examination so perfectly. After asking the investigation, here I diagnosed my patient is not ectopic because her UPT was negative. Asking on the ultrasound, they told me like she has a cyst or whatever. No, the window part was like the examiner was not interested in my management. She had a sparkling eyes. She closed her file and she asked me, give me one line management. Trust me, guys. I was like, okay, I will do whatever the management, like one word. I told her, not discussing because this scenario is coming on the way, so I don't want you to give the key. I discussed to one line of word, but I saw the time. There was 10 minutes left. She was looking at me and I was looking at her. The long case, I'm talking about the long case. She didn't ask a single word. Instead, she take my introduction, what I do, what I like in traveling. There was a gossip going on in the MRCPI room. Trust me. If you able to impress, I'm going back. If you're able to impress your this examiner is already sitting with that. You do your history examination so perfectly, investigation so perfectly, For the management, they say, okay, we are not interested. She knew everything already. Why? Because the way you approach towards your patient, that matter. History is not difficult at all. This have been in your medical schools. This is not a new slide for all of you. All of you know it better than me. Introduce yourself. You do the greeting. Hi, I'm Dr. This. I'm your doctor in the clinic today. May I know your name and age, please? If they have given you name and age, you say, may I reconfirm your name and age, please? If they haven't not given, you can ask your name and age, please. Okay. You establish the agenda. Agenda is like you tell the patient, I have been seeing you are here for this is problem. We will discuss it. I will ask certain few questions to know you better. Then we will do your examination. We will order some investigation, and we will discuss a safe management plan. And I will give you information leaflet. I will like whatever. That's the agenda in one line. Then history of presenting complaint. If she has fibroid, ask any pressure symptom, quantify her heavy menstrual bleeding. You knew this part. If she has, for example, tuberculosis, you ask about the cough, sputum details, night sweats, X-ray, treatment has done so far. HOPC will be according to your patient complaint. You knew that. Only 4 or 5 questions will give you the clue. 4 or 5 questions according to that. If if she has high blood pressure, when it started, whether she is on the follow-up with her GP, whether she consulted her doctor before embarking into the pregnancy. Like any case, HOPC will remain according to that case. But from here, starting from here, this is the same. If someone is able to cram up this slide, no one gonna fail that candidate. Please, please, please. If it's heavy menstrual bleeding, the patient is coming with the fibroid scan. Please don't leave this. You just ask HOPC and now you are jumping onto the examination. You just made a one wall of the room. The room is incomplete. First, make 4 walls. Ask obstetrical history, number of cesareans, number of pregnancies, mode of delivery. It is so important. You are planning, for example, take that MRCPI candidate patient example, Mrs. Lena Jones. We have to do her myomectomy. She is previous 3. On the table, you knew this. You didn't ask in the history. In the gynecological history, ask about her menstrual cycle. Okay, here, how to signpost your patient. There are certain intrusive questions for which we will signpost our patient, like the sexual history. You will ask, pardon me, do you have any sexual shared infection with your partner? Signpost here. Okay, if you forget to signpost, like, do you have sexually shared infection with your partner? Now you remember, you say, pardon me for asking this question. Okay, like, don't tell patient, sorry, I forgot to ask. Don't do this, please. This is your daily routine in your private practice. Forget about the public sector because you don't have much time. But here you have solid 25 minutes. Please, please, please. Medical history. Do you have any disease for which you visit your GP frequently? Blood pressure, sugar, whatever. Any surgeries on your tummy or down below? May I aware of any things I missed in the history? Keep on asking. Ask her personal history. Smoking in Ireland and UK or in the US, every person do the smoking, every third person. So you don't be too sorry for asking, do you smoke? Don't be sorry. Ask her, do you smoke? If the patient, like, it's according to the patient. If the patient attire is this, you can be like saying this, pardon me, do you drink alcohol or any illicit drugs? Communicate with your patient like normally you do. For mental health, ask about how she has been feeling for past few days. This, guys, this A and B is your patient safety. If you miss this, I will say you only make 3 walls. This is the 4th wall. Any allergy from the food and drug. Ireland people are so crazy about the patient safety. If you miss this, you're gonna lose your marks. If your patient says no, I don't have allergy, but still if you didn't ask, you are going. The blood group. Say for example, you forget to ask the blood group. The patient is O negative. She is there on the operation theater table. She is O negative and she is Jehovah's Witness. What you gonna do? She's bleeding. You forgot to ask. So importance of the history, Like here in the management on the operation theater, the patient is for myomectomy starts from here. You already know your patient is O positive and she don't have any reservation for blood transfusion. BMI, usually they are aware of this term. They have the chart. You can ask the weight to height ratio, but please address her BMI as well. Anything, any confusion in this format? Any confusion, please. I'm here to answer any confusion in these 4 walls. And tell me any reason to skip a wall. You can't make a triangle room. You can't make a junky monkey room. Any reason to miss these 4 walls? Please. Any confusion, any question? Are you with me? Let me go in chat box. Are you with me, guys?
Yes.
Yes.
Okay. Keep on telling me because sometimes my pace will be so fast, so I will slow my pace, okay? Okay, coming to the roof, can I have your beautiful ears? I just want to say something. If I ask you a glass of water, you should give me a glass of water. Please don't dump the bucket full of water on my head. If examiner, the poor examiner, he is asking you to perform local examination or he is asking to perform you specific examination, what is the purpose of taking blood pressure? What is the purpose of doing this? Okay, for the history part, here you talk with your patient. The patient is usually a doctor. She mimics as a patient. Here usually is the doctor. Examination you won't perform on the real patient. There will be a dummy, mannequins behind. They can give you any command. You know, examiner really mind. I have seen the expression of the examiner. If he asks you to perform the specific examination and you are like enthusiastic, you go for taking the blood pressure pulse and you tell the characters of the pulse, you tell everything, you tell the unit of the pulse, no matter what. He didn't ask for it. Please follow his command. He is your examiner. He is the one who decides will you sit on consultant seat today or not. He is very important for you right now. If he asks do the examination, you will do both. If he asks do general physical examination, which usually they don't ask for it, you will do the general physical examination. If he asks perform the examination, automatically both of things. But if he said local examination or specific examination, do only that. For example, I asked you to perform, there is the case of primary amenorrhea. For example, I gave you a command to perform the specific examination. What you will do? Anyone, unmute your mic and tell me the specific examination of primary amenorrhea. I asked specific examination. Guys, tip of iceberg.
Sorry, is someone speaking?
Yeah, I
Sorry,
can
in
hear you.
general physical,
Okay,
we will,
okay, you
in
can.
general, okay, thank you. In general physical examination, we'll look for the secondary sexual
I didn't
characteristics.
ask. I didn't ask. Sorry to interrupt
What did you
I
ask?
didn't ask for general physical examination. Just give me local examination of primary amenorrhea. Local examination.
Just abdominal examination.
Okay.
And the examination of the
examination.
external genitalia. That's it. And
Yes,
if the patient
yes.
is, and yeah.
So in the local examination, you will tell the formation and fusion of the labia. You will tell me about the clitoromegaly. You will tell me the presence of the blue or pink septum. You're gonna tell me the presence or absence of the dimple. This is all what I want to hear in the local examination. There's no need to tell me the blood pressure, please. Follow the command. Follow the command. This okay, like I can't emphasize more. Please. This slide is your bread and butter. If you cram up this slide and you understand the meaning of the command, you're gonna do it. You won't just pass. You will gain top scores. Please. Okay, coming toward the doors, investigations. You only have to ask specific investigation. I will tell you in a way like how to ask your investigation perfectly. I have that part with me. So if a patient has the primary amenorrhea and you keep on asking her liver function test, for example, you are asking her chest x-ray, you're asking her ECG, You are saying, I want to be a safe doctor. Please, please, please. It's mean the door offers safety, but reason is that you are putting a garage door here. This is your patient. She needs only specific door. You are putting a garage door. You are putting a main door. Like you, I can't tell you how much you offend your examiner by asking all the investigation, by putting all the doors of the home on one room. You don't do that. For the management part, usually they can spare you if you say, for example, you did not read that case perfectly, you don't know, you didn't revise it well. What you do in your clinics, what you do in your hospitals, what you do daily, speak those lines in a simple way. Don't go for the perfect management. This is the case. I told you here the examiner closed his file, both of the examiners, they closed their file and they said, give us one line word. They even didn't ask me the management. Okay, so going to the next slide. Guys, are we able to start it? Let's dive in MRCPI OSCE. We will do the true recall station. May I know the name of volunteer, please? For SPT, who was our volunteer? And trust me, the one who gonna practice with me today, she cannot fail this station. In fact, she will gain the top scores. Why? Because once you rehearsal, that's make you perfect. Name of volunteer, please.
Ma'am, I can do, but it is primary amenorrhea?
No. This is the scenario.
Okay.
Who was the volunteer? SPT format, I already told you guys. There is a patient with a complaint and she has ultrasound with her. That is our SPT. And please, 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 let me go back. This is your SPT. A silent examiner, a patient who has questionnaire, but patient don't hold the questionnaire. She knows her questions. This is a trap. You enter and you start talking to your examiner. Please don't do that. Only give her sticker. Say, I am, okay. Other thing is like introduction. You say, I am Dr. Monica, for example. You don't say this. With your colleagues, you don't tell doctors in each other, with each other. You don't say the word doctor. You just simply say, I'm Monica. Okay, one of the exam candidate and I am ready for my case, whatever. Give her sticker, here's my sticker, give her sticker, and here time starts. So SPT is here, any volunteer, I need a serious volunteer who is willing to confer her ceremony. I need a serious volunteer, please. It will be easy. What happened?
Moni, you can do it.
Yeah,
Although
I
it's
can.
not primary
I'm thinking
amenorrhea.
actually. I can do it. I think I can do it. Though I did not do
Yeah, sure.
IMP before, but I can do it. She's young, na, so it may be PID. Okay, ma'am, I'm ready.
Okay, that's good.
That's perfect. Okay, Monia, I will. Your name is Monia.
Yeah, my name is Monia.
Okay, Monia. Enter into your cubicle. You have to. Okay, before starting, I will mark your time. 10 minutes. It's okay. Don't take any tension. Whatever comes in your way, perform accordingly. I will, because I am your patient. So I'll be keep on asking the question from you and try to finish it in 10 minutes. Okay, I will put the timer for you. You just go with your flow. Okay, it will be easy and trust me, you won't forget this station ever. I'm starting. Enter your cubicle.
Ma'am, should I start with the examiner first? Like I am Monia Zaman. This is my sticker, or I will come to the patient directly.
Yeah. You enter the cubicle. You give me
Okay.
your sticker. I will mark your sticker on your answer sheet, and the patient is sitting in front of you. I am your patient, by the way. So I'm sitting in front of you, and you start interacting with me. Okay, I am resetting your time. Go.
Hi, I am Monia Zaman. Here is my exam sticker.
Okay. Proceed with your case. This is your command, Monia. This is your
Yes, I have
command.
read that. I have read the task. Hi, I'm Dr. Monia Zaman, one of the doctor in this gynae clinic. May I know your name and age, please?
Doctor, my name is Anuj and I am 25 years.
Hi, Anod. Anod, may I know what you are here for? Actually, what concerns bring you here today?
Doctor, I was having a problem with my periods and I went to my GP. She gave me treatment and then she asked an ultrasound report and she said me I need to visit you today and you will tell me what's going on.
Okay, it's okay. Don't worry, we are here. I will explain you everything. But before explaining, I need to ask you some questions. May I proceed?
Yes, doctor.
As you said that you have some bleeding issues, can you exactly tell me that what is the bleeding issue, when it started? First, when did you notice?
Doctor, it has been 3 months and I bleed in between my periods.
And how many days this in between periods this bleeding stays?
Doctor, it stays like for 6 days or 7 days or 10 days. It's unpredictable.
What was the amount? Is it too much or it is spotting?
It's spotting.
Spotting. Is it associated with any pain?
No, doctor.
Is it associated with any triggering factors?
No, doctor.
Are you married?
No, doctor. I am in a relationship only.
Okay. May I know your last menstrual period?
It was the start of this month.
Your period is regular?
Yes, doctor.
And your pap smear is up to date?
Yes, doctor.
And is there any history of any sexually transmitted disease?
What is that, doctor?
Any disease which is related, as you said, you are sexually active. Any disease which is related to sex, that like any infection from down, any abnormal discharge from down, any abnormal pain?
No, doctor.
Okay, nice. Okay, and as you are unmarried and you have a relationship, are you using any contraception?
Yes, doctor. Barrier.
Okay, that's good. And are you taking any medication regularly, for any condition by your GP?
No, doctor.
You have any allergy for food or drug?
Yes, doctor. I'm allergic to peanuts.
Next, okay, I will mention in my notes. And do you smoke or take alcohol or any recreational drug?
No, doctor.
And how is the support at your home?
It's fine, doctor.
Do you know your blood group?
It's B negative.
B negative. And do you know your weight and height ratio?
Yes, doctor. It's 25.
25. Okay, that's good. 25. And do you have any history of surgery before in your tummy or below tummy?
No, doctor.
Any concerning family history?
No, doctor.
Thank you very much for sharing all these things. Do you want to add anything? Do you want to inform me any other things?
Doctor, when I start bleeding, doctor gave me a certain medication, and she said me like I have something because when I meet my partner, the bleeding was more. So she told me that there is a growth and ultrasound. I don't know about that. I'm very worried.
Don't worry, we are here. Ma'am, can I get the ultrasound report?
No, you don't ask, ma'am. You just simply say me, can you show me your ultrasound report?
Okay, can you show me your ultrasound report, please?
Here is the report. Now examiner will slide this report in front of you, okay?
Okay, so it's endometrial polyp, okay. Okay.
What's wrong with me, doctor?
Don't worry, we will explain you everything and we will manage you. But before that, I want to examine you. Is it okay with you? In
Yes,
front of the
doctor.
chaperone with your permission.
Yes,
Ma'am,
yes,
here
doctor.
I want to know that should I explain that how I will examine like pulse, BP, temperature, or just I will tell that I will examine you, then I will go for the investigations.
You just tell. Go for the investigation. You already have one investigation. You
Yeah.
already have.
Okay. So I have done the examination and I have got the report of ultrasound. See, Mrs. What is your name? I forget the name. What was the patient name,
I
ma'am?
really
Sorry.
mind if you forget my name. My name was Anoop, doctor. My name is Pretty.
Anup, Miss Anup. See, according to your complaint and according to the ultrasonogram report, there is a piece of you can say piece of muscle, which is 2 centimeter, which is inside your womb. Are you following me?
What do you mean by doctor?
It is an extra growth inside the womb, same like same like extra proliferation of muscle inside the womb, which is causing your bleeding at present.
Or what are you talking about? Extra? What is extra profession? I can't understand,
See,
doctor.
if you want, I can draw it also for you, so you will
Yes,
understand
please.
more.
Yes,
See,
please,
this is
doctor.
your womb. See, this is the womb. In between, this place should be empty. You can see your ultrasound report. There is a small, enlarged, small, long elongation. This is called polyp. Polyp means extra growth from it. Polyp can be from the mouth of the womb, or from the inside. For you, it is from the inside. That is called endometrial polyp, which is 2 centimeter.
Is it cancer?
No, dear. It can usually, I cannot tell you 100% now, but usually it is benign, and after the histopathology we can tell you. But at present, I cannot tell it is cancer or benign. As far as for me, according to
Benign,
your
doctor.
history and this one, yes,
What
tell
is
me.
benign? What is histopathology? I can't understand.
Yeah, histopath means you have to now the management is we have to remove this one by hysteroscopy, which is a procedure. It is a day procedure, and we will take out this one and we will send to the laboratory to see what type of growth is this. Usually it can be normal growth, I mean without any bad condition. Sometimes it can be with bad condition, but that is also treatable. You don't worry. Are you following me?
Why this happened to me, doctor?
Um,
I want
this
to be a mom.
there is no issue.
I'm
There is no
planning my baby.
see. Yes, I can understand. You can be you can have a baby. You don't worry. It's a small thing, and still I'm telling you it's not cancerous. Still, we will get the report from the laboratory, and you can be mother in future.
But doctor, what are you talking about? What the procedure are you doing? You will do a surgery on me?
Let me explain you. It's not me. I will inform my consultant, and she will do the procedure. It's a procedure. We will give you medicine to sleep, and then from your down, we will put a instrument to remove this extra growth. That is by hysteroscope. The name of the procedure is hysteroscopy.
But
It is
doctor,
only
can I have some medicines or tablet for it? I can't
you
do that.
see. There are some medicine which can stop your bleeding, but till this will be not removed, you will suffer every month. The definitive treatment is the surgical procedure to remove it.
But doctor, I think every procedure has risk. The fancy procedure you are telling me, what are the risks with that?
Okay, yes. Of course, you are right. Every procedure has, but this is minimum risk with this procedure as it is not major. We will give you some painkiller also. You can get some pain for few days. You can some get irregular bleeding also for first few days, which will be controlled by the medicine.
Time up. Very well presented, Monia. Very
I
well
don't
presented.
know, ma'am. I don't know how it was.
Time up. Okay. You did really well because it was your first time. So if I had been in your place, I would not speak like this. You did it very well. The way you offered me, you want me to draw it, that was absolutely beautiful. I like it when I was being like, I can't understand your fancy terms. You really addressed me that. But you want a honest feedback or no? Tell me that.
I want honest feedback, ma'am, because I want to learn.
No. Okay, that's a perfect for you. I would say it's a passing station. If there is no problem with the time, you have been answering all my questions. It's a passing station for you. Okay, but I want you to do the top scores in this station. So I will tell you your feedback. This was my detail. I changed my name. I like the Anu's name today. So you entered in the cubicle very beautifully. Would you like me to perform your station?
Yes, ma'am, it's better for me, so I will understand where I was wrong.
Okay. Anyone of you give the feedback about the mistakes Moni are done? Any volunteer who can make this station better? She
Can I
did
say?
it very perfectly, but I
No,
want
it was
anyone.
great. And can
Yeah,
you
it
hear
was
me?
great. Yeah, I can hear
Okay.
you.
So I think she did very well. I mean, doing it for the first time in front of everyone and not knowing the
Yeah.
case. But I think a few things to ponder upon. As it was an SVT, I think she should have not gone into the very detailed history. I think a fair bit of history around intermenstrual bleeding, how much is the bleeding, and she's widely stable kind of thing, and just going on to the report. And if she had taken treatment and if she's compliant with it, how is she feeling? Is she feeling better or not? So that she can hop onto the management. I think the prompt was to explain what is this and what is going to happen, the procedures and the medication. So she could have saved a lot of time. And then she could hop onto the hysteroscopy and she could involve, like, openly ask the patient if it is causing a problem. We can do a simple procedure, which is called
You already knew that
hysteroscopy.
it's causing the problem. She already knew that.
Yeah,
And
but
she
to involve the
caused that
but
problem.
but to involve the patient, they can he can say, right? If this is causing so much of a problem, he can remove it, but it's not 100% sure that it will not come back again. Sometimes the biggest worry is that it comes back.
Yeah, I had this
And then
question. I had this question
also
again or no.
explaining also explaining the biopsy that will send it from, I think she said that we'll send it by
She
for
said that.
biopsy.
She said that,
Yeah,
but
yeah.
okay, let me solve this station. You enter in your cubicle. Hello, my name is Dr. Saba. I'm one of the exam candidate today. This is my exam sticker. Proceed with your case. I, Now I turn my face towards my patient, and before that I didn't said myself doctor. I just simply said I am Saba, one of the exam candidate, because I was talking with my examiner. Now I'm talking with my patient. So for her, I am doctor. Hi, my name is Dr. Saba Alee. I'm one of the doctor in the clinic today. May I know your name and age, please? Anuj, 25 year. What would you like me to call? Is Anuj is fine? Yes, doctor, is absolutely fine. Anuj, I can see that you are here with a problem in your periods because it's given here. I know you are here. I can see that you are here with the problem in your periods. It's bothering you since 3 months, and you are here with the ultrasound report advised by your general practitioner. Am I right? Yes, doctor. Okay, Anuj, we will discuss this report. I will guide you, but before discussion, I would have to ask certain few questions to know you better, to understand you better. Then I will examine you in the presence of Chevron. I will look into your investigations you already got, and I will discuss a management plan. I can provide you the information leaflets, and I can book your appointment with the consultant or whatever needed at the end. Is it fine with you? Yes, doctor. Okay, Anuj, you tell me about yourself, how this complaint started. Please tell me more details. Doctor, I had on and off bleeding for 3 months, for which I went to the GP. She gave me the medicine, but it was not settled. Then she advised me an ultrasound, and she said there's something wrong, and you have to go to your GP. And I'm here for you today in your clinic. Okay, I got it, Anuj. And what was the amount of the bleeding? First, address your IMB, intermenstrual bleeding. What was the amount of the bleeding? She told you it's a spotting. Does it was associated with the pain? No. Okay, for intermenstrual bleeding, what's in your mind? You ask about the discharge question. Any discharge down below? Pardon me for asking the intrusive question. Do you have sexually shared infections with your partner? And sexual shared infection, which she said, okay, no. Do you notice that any problem with your relationship? Does it start after sex? No, doctor, I didn't notice. Do you have any fever, foul smelling discharge? No, doctor. Do you have any weight loss? Anything like ask any questions related to the intermenstrual bleeding. Then you have to ask all these questions. Monia did it very right. Even when I display, she was missing these things. I display these slides intentionally so that she can come back. She asked me family history after I displayed this slide. That was perfect match. But you have to ask in one-liner. SPT, you have short time. Please touch these headings only. You ask, have you had any baby before? No. Here, gynecologically, don't ask sexually shared infection, don't ask period details. She already told you. It's her problem today. You just ask, is she using any contraception? Because you know the risk factor. Here, tamoxifen, you need to ask if she is taking or not. Medical, you have to rule out obesity, diabetes. These are the risk factors. So you ask any disease. Say, for example, she says, I'm asthmatic. Okay, I forgot to tell the Monia, but my Miss Anood is asthmatic. Okay. Any surgeries on your tummy and down below? Do you smoke? Pardon me, do you use alcohol or any illicit drug? How have been sport? How have been sport at home? Do you have any allergy with the food and drug? May I know your blood group, please? Are you aware of your weight to height ratio? Now, thank you so much, Mrs. Anood. You want anything to add on this? No, doctor. Okay. Anood, now I would like to examine you in the presence of the chaperone. Coming towards your investigation, Anood, in the clinic, okay, before jumping to the ultrasound, how to read this ultrasound perfectly, please, all ears towards me, all ears towards me, beautiful ears, please. Any investigation which comes in your exam, how to read that? You will say, I can see your name, age, your hospital number. Without seeing these three words, you cannot touch the investigation of a patient. If she is Mrs. Anood, we can have two Mrs. Anood in the clinic today. How you can mix? She has fibroid, she has polyp. You cannot mix this. I can see on okay your ultrasound. May I have your ultrasound report? Here is doctor. Okay, I can see on your ultrasound your name, age, and your MR number. I can see there is, you have done the scan from down below, they entered the probe or whatever, you even don't mention down below, forget about this. We have your ultrasound report. I can confirm your name, age, and MR number. This report belongs to you. The report says there is a growth inside your womb. Anood, this is the drawing I'm drawing for you. In every station, you have a paper and pencil. Please, that is for usage. Use that paper and pencil. Use that paper and pencil. I can't emphasize in SPT, you have to make drawing. You have to make drawing. Please. If you will do that, your patient and your examiner, you will see their impressions. They have sparkling in their eyes. They like the way you are teaching your patient. You will simply say, okay, see, this is a balloon mimic a womb. Inside the womb, we have the three layers, inside layer, middle layer, and outer layer. In inside layer or the inner layer, there are some growth. Normally, it sheds off in your periods, but what happens, it is having an outgrowth. This I can say, this is an outgrowth. This is not a dangerous condition. It can be very common. The presentation is real. It can become with the bleeding. I'm draw okay. It can come with the bleeding. What we have to do, it's not a bothersome condition. This, in our medical language, we call it a polyp. It can be like, if you want to tell in the detail, okay, you can say it can be in the womb, it can be at the neck of the womb. Forget about. Don't tell her all the guideline of the polyp today. Just talk about the endometrial polyp. Okay, what do we have? Let the Monia, one mistake you did not let me speak. I was trying to ask you questions. I had a full question paper. Here you explain me the diagnosis. You answer my question. What's wrong with me, doctor? You answered. But what about the other question? The moment I said in a cancer, you said no, it is not cancer, Anood. The condition is benign, that is not harmful, that don't have roots in your body. That's not a cancerous condition. Every patient can have this, and it is a treatable condition. It's not something you have done. She will ask what I have done wrong. It's not your fault. It's not something you have done wrong. The moment you told her, you simply tell her, here we have a tiny camera called the hysteroscope. The tiny camera goes into the womb. We enter the womb. We will make you pain. Okay, guys. Why you all are telling me the hysteroscopy in general anesthesia, or she need to admit it? It is a day case procedure, or she need to admit it? Indoor or day case?
It's daycare.
Daycare.
Ambulatory is preferred nowadays.
Yes, Monia, you're very right. You said her, this is the outdoor procedure. Outdoor procedure. We will call you 2 hours before. We will give you painkiller. My patient was asthmatic. In the history, she told me in the medic asthmatic. I will avoid giving you the routine painkiller. I will give you simple paracetamol as a painkiller. We will enter a tiny camera. I would like to draw the camera. To be honest, I would like a probe, draw a probe. This is very tiny. It will enter in your neck of the womb. We will remove this growth. We will send in our laboratory. They will analyze what are the cells, what are this condition. They will give us the report. Post during the operation, there are certain risks. I would like to tell you. My purpose is not to make you scared. If she asks, there is a risk, she will ask, is there any risk? If she doesn't ask, tell her. Their risks are very minor. It can be bleeding, it can be infection afterward, you can have light cramping right after the procedure, you can have vaginal discharge, you can have infection, and rarely we can have perforation, but with the right strategy, these risks are almost nil. You won't face this, hopefully. We will make you pain, you will have painkillers. After that, you have to take certain precautions, for example, avoid sex, avoid tampons, all that you will tell her, you will summarize in one line. Ask her in between, you want me to add anything? Are you with me? Are you understanding me? Please, please, please. Your patient has a lot of questions. For example, you are demonstrating the polyp. You're demonstrating it right. It was second question. I had 5 questions ahead. I'm your patient. I had 5 questions to ask. Your bell rings. You will score 2 by 10. You read polyp so right. You know how to do. You know what is hysteroscopy resection. You're gonna tell her in the moment. You're gonna tell the risk, but time's up. What you will do. So keep yourself summarized. Please touch this slide. Don't leave this slide. You have to ask the room. You have to ask about all the 4 walls, but quickly. Then go the examination, explain her investigation, and ask her, interrupt her. Do you want to ask anything? She will ask, doctor, what are the risk factors? Tell her, da, 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 da. You want to ask anything? She will tell, doctor, I'm afraid I want to be pregnant. Actually, Anood, this growth, the baby has to implant or the baby has to grow inside your womb. When we remove this growth, actually, it will enhance your fertility. It will help you to being a pregnant. What is the follow-up, doctor? Will it grow? It can grow, but we will keep you with the follow-up. If the complaint comes in your way again, we can do an ultrasound. We will make you, if she is concerned about, say for example, she concerns about her fertility, you're gonna refer her. You will follow her with the histopathology report. You tell her the lab report, which is called histopathology in our term. You will come with that report. We will do a follow-up. I will book your appointment with the consultant. Am I clear to you? Are you with me? Can anything which you want to ask, you can ask, please. Please, please, please let her say. At my time, when I told my patient about, I draw her, I told her anything, I tell this is a hysteroscopy resection, for which we use the word hysteroscopy resection in our medical term. It is transcervical procedure. We enter from neck of your womb. You see, you notice your examiner is there. You tell the procedure name, and for your patient, you have to explain. Examiner is silent. He has nothing but to listen you. He will mark you. He will do tick, tick, patient safety. She asked the blood group, tick. She asked the allergies, tick. She is safe doctor. She explained well, tick. She was interactive. She was simple. She avoid medical jargons like she is not using fancy terms, tick. She give the information leaflet, tick. She asked for the follow up, tick. This is her. This is the examiner key. So after that, you ask for the follow up, and you ask her if she want to add anything. She will ask, "Do you need an operation?" This is you say, "No, it's not an operation. It's a just day case procedure. It's just like mimicking a tiny camera going inside the womb. We will take this out, and you will be fine. You can drive home after that. You can resume your daily routine and all that." So guys, Monia, now you know your mistakes.
Yes, ma'am. Here I have a question, ma'am. When she is asking me, is it a cancer? Should I say it is benign? Because in histopathology only confirm this one. No? So I should say that most probably it is not. But after the report, I can confirm you. Like this, I will tell, or what I will tell.
Don't tell her. The one who are rare things like you cross the road, you can have accident as well. You will tell her, please, if you cross the road, you will have accident. You don't tell. If someone asks the way to the university, you will tell, please follow this road. Will you tell her she can have an accident? No. Why are you telling her? Your patient is anxious. Your patient should be smiling. Your patient should be smiling and confident in you. Your patient should feel safe. Like imagine there are alligators in the water and you are sitting in the boat. You have to take your patient inside that boat. She should be safe with you. You can tell with the proper precautions we can avoid this complication, whatever, like if you are telling complications. So here you will say, no, it is not cancer, Anoot. We will do the lab report. That's it. If she asks, is there any risk of cancer or any, it can be, but in your case, you are young, it is very rare.
Okay. Yeah.
You got me? Okay. You said, Monia, you said the triggering factor of the bleeding, which was like you asked about the pain or that thing, that was an extra details. And I was allergic to the pinners. You beautifully said, I will mark in your notes. You beautifully said that I like that, but the B negative, you should also say that I will highlight in your notes. Okay.
Yeah. B negative.
And other thing, I don't know where I write. You said, of course. I forgot where you said, of course. So for the patient, I try to be these things like being judgmental. Like if I was worried, it's okay. These type of words you don't say. It's not okay for the patient. She's here because she's not okay. You see her, we will make it right. We are here to help you. Do you have any question in your mind? You give her contact number. This is 24/7 hospital contact. This is information leaflet. You want me to add anything? I'm booking your follow-up appointments with the consultant. You want to ask anything? Please say 4 or 5 times. Do you want to ask anything? Because if the patient she goes, your bell rings before the patient questions are finished, you are in trouble. So, are you clear with the SPT now?
Yes, ma'am. It's really, thank you, ma'am, because it's okay. It is, I think it's, automatically coming. Even also when I'm talking to you, it is coming. It's okay. I have to change this one. I have to change.
Yeah. You please just answer my question and be silent and smile. Look at me and say, do you want to ask anything else? I will ask next question. Give me time to ask questions. The patient have the question. Please. Let her ask. How to read a report? We always discuss. Monia, tell me how you will read an ultrasound from now onward.
Yeah, I will tell the patient, in your report, I can see your name and your hospital number, and I'm confirming that it's your report. So in the report, it is ABCD.
Yeah.
Thank you, ma'am. This is the first time I'm learning this one. First time, ma'am. This is the first time I'm learning.
You won't forget in your exam, okay? So the procedure, the patient is not interested, please. The patient is not only, she want to know this is not a big operation. It is just a day case. You will avoid answers if she is asthmatic. Otherwise, you will give the painkiller. The important safety point we forgot to mention, even I forgot to mention, we will ripen your neck of the womb if needed. We will give you certain tablets to place underneath your tongue, right? If needed, we have to do that ripening. So the risk she will ask, but you make sure your patient gives like her face. She should not be afraid. You look at her face, and if she gives an expression like she's afraid, tell her that these things are very minimal. With the right strategy, we can avoid this. The expert hands with the right strategy. Asthma part was the safety point in this case, but I didn't show you, so I was not expecting from you. Otherwise, polyp, you answer about the fertility, it will improve her fertility. Post-operative, what are the cares? She will have the cramping for which you can give her painkiller. She can have mild spotting. She has to avoid the sex and tampons for a week or so. She has to return for the follow-up. You book the follow-up before the patient leaves. In Ireland and UK, you always book the follow-up appointment. Please mark this in your notes. You have to do the follow-up appointment for your patient. These are the questions and you will answer in these questions. So these are tips. Whenever you see a patient, guys, everything we have discussed so far, build up to this. This is the core message. How to solve your SPT, any SPT. Patient comes with anomaly, patient comes with cystic hygroma, patient comes with the gastroschisis, patient comes with the gynae report, obstetric report, any report. If there is SPT, patient comes with the complication. Say for example, patient comes with the vaginal tear, patient comes with anything, any SPT. Whenever in the long case or in the SPT, when you see the patient, let the patient open the station. Open and it don't close the station. Don't you start asking like, okay, when the bleeding start, why it is start, how is happening. Please let the patient speak. Patient is your opener. You know how to open the bottle, soda bottle? There is an opener. So for your SPT and for your case, the soda bottle will be the opener is your patient. PPPP patient, PPPP opener. Please, don't forget this. They should be open-ended start, empathetic, simple, calm, avoid jargons. You say this is hysteroscopic resection. No, this like we will remove this from neck of your womb with a tiny camera, tiny gadget, which we call hysteroscopic resection. Which we call this. But first tell the explanation, then tell the medical term. Always draw it. It has a mark. It has 1 or 2 marks. When you draw it, it becomes easy for your patient. 3 or 4 times you have to ask, are you with me? Are you following me? Am I audible? Am I clear to you? Like change on the phrases, but keep this question 3 or 4 times. Let patient ask her questions. Let her add into history. When you are done, you ask, you want me to add anything in the history? She can say, oh doctor, I forgot to tell you I was asthmatic. Don't interrupt her. This is not a layman patient sitting in front of you. This is a doctor mimicking the patient. So she know you have limit time. She won't tell you irrelevant thing. Trust me. She won't tell you what she was wearing on her wedding day. She won't tell you irrelevant it is. She will tell you about this patient only. Okay? Don't interrupt her. Please. Patient will mind. Examiner will mind. If breaking bad news come, like she has an anomalous baby, it's not okay for her. Give a pause. Deep into the moment, goes deep into the moment. Offer her vibes, offer her water. If any complication, she is here with the tear. You say, I know you have been facing so much trouble. I know it's not easy for you. Do the risk management if there is a complication. So you modify your SPT according to your station. Here, there is no need to risk management. Do you need debrief that duty of condor or any form filling or incident report? No, it's a simple polyp. But if the patient has been with the fistula, if the patient has been with the perineal tears, can you avoid risk management in that case? No, not at all. So these are just tips. You can solve any OSCE station if you know the tips, what to do when it comes, what to do when it comes. When a patient loses her baby, intrauterine fetal death, please, she lost her baby. Give her time. So here your 50% marks will be here for taking a pause, offering her water and wipes, asking her she want to involve someone, offering her if she don't have phone, offer her, do you want me to give you phone? You want me to call your partner for you? You want me to call someone for you? Are you able to listen? Do you want me to postpone the session? We can discuss it another way. I can see you are crying. I'm here for you. in the next pregnancy we can prevent this. Like, give her some positive hopes. Your marks will be for this. If the breaking bad news, your marks will be according to that. If there is a complication, your marks will be lying in the risk management. Here, simple polyp report, your marks will be for avoiding jargons and drawing the case and asking her question, like let her discuss her questions. So SPT, your questionnaire is with your patient. You have to do you have to let your patient speak. Don't interrupt. This was the key of your, and Monia did it very well. She told hysteroscopic polypectomy. She avoided and said, like, if has been asthmatic, cancer risk is low, lab report for confirmation. She was reassuring me. She was with me. She told me I can be a pregnant. Okay, in Ireland, you can never ask, are you married? You simply ask, are you in a relationship? Or you can say in a way, because sometimes if there's a vaginal discharge, you have to ask about the STI. So what you ask, are you in a stable relationship? That's the question. It will rule out multiple sexual partners. It will rule out whether she is married. She can tell you the answer. She can tell you, yes, I'm married, doctor. Don't ask, are you married? People will mind. They have relationship, it's fine. So the word married, please leave, exit the word married from your history from now onward. You will always, are you in stable relationship? Are you sexually active? You can ask this. So guys, we did this part SPT in the structured discussion, and now the big crocodile is the long case. Guys, any question for SPT? I'm here back. Any question?
Yes, doctor, I want to ask, that is after the history, we have to examine, if the report is not given to us, then we should have to say all the investigation, or we just like to say that I will review your investigation, like this.
Okay, Asra,
And
in
then we have-
simulated patient task, it is not a wide station and they are not giving you much time. You won't perform the examination. SPT, you can never perform the examination. Examination itself takes 6 minutes. They won't give you examination in SPT. You will simply say, I will examine you in the presence of Chevron. Just one line. You touch, because your examiner should know that, if you had time, you can do the examination. SPT, the patient will be with any presentation. For example, the patient has the perineal tear. She is crying. What you will do? You will say, she has done all the things, like the tear is stitched, but she ended up in the fistula, she's crying and weeping in your clinic, and you are here, you're a registrar, you are going to tackle her. You will first focus on her weeping and crying. You will make her calm. You build a rapport with this patient. Then, if you don't, I know you have been going, a lot of things are going on your plate. It's not easy, but please, I have to know you better. Can I ask certain few questions with your permission? Ask your HOPC one-liner. That's it. Now, I would like you examine the presence of the chevron. I would want to know the condition of your wound, any discharge down below, any complication. I would like to examine that area, if you allow me. Because the complication patient, the angry patient, you have to be scared. You have to be like, if you allow me, please. Your body language should not be like weeping or crying, but it should show some empathy. It should show some empathy, and patient should be calm down, and she should contact you. She should say only Isra knows how to deal me. So here you asked about the investigation question. You will see if a patient has the fistula or patient has the complication. You won't ask for the fancy investigation. You won't ask. Do you say, may I have a look into your notes, please? If she had any investigation, the examiner will slide on your table. Otherwise, she said, the doctor already checked me, or I don't have notes. The SPT parts, investigations are not necessary. The patient answers are necessary. Here, if she is angry, you have to deal her. She will ask, what is the future complication? Will it happen with me in the future? I don't like your hospital. You guys did with this me. Are you punishing the doctor? The questionnaire lies in the risk management here. So don't treat the patient in the exact format. You can modify this according to the complaint of SPT. I'm sorry. Here. This you should speak in one line. You should know, I would like to examine, I would like to look into the notes, but the patient is here in this phase. SPT patient is here. She already done with the investigation usually. She's already done with everything. So she's here. You have to explain the management part of your this. Either risk management, either polypectomy management, either counsel for myomectomy, either counsel for any treatment like for obesity, she's here for the antenatal. You have to, SPT belongs to this part, window part. Are you with me, Asra? You got your answer?
Yes, doctor. Thank you so much.
Yeah, you don't need to ask, I would like to have some journal, physical journal investigation, then specific investigation. No, 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 it's not a long case, please. You just say, I would like to have, I would like to have look into your notes, into your investigation if you had it with you. Okay? So guys, feedback or any other question about SPT, I want you to be expert of SPT today. No question should be left. Ask any question about SPT, please. Should we proceed? A bit silent.
So I have one question.
Yes.
So if we are running short on time, like during
Yes.
SPT, can we skip the family history and social history and all of that? Or there is like scores or points for that? Because if
What's your good
we are
name?
running short, my name is Hira.
Hira, you can skip the family history, but what if you do it in one line? Are any significant history I should aware of in your family? Do you have any like you make a flow? You ask like, do you have any medical disease for which you visit your GP frequently? Any searches on tummy or down below? Any family history of significant? It just take your 1 minute, please. It just take your 1 minute. Because in SPT, the history part you end up in 2 or 3 minutes. In 2 or 3 minutes, the history part should be ended, and you ask the question you ask from your patient, you want me to add anything? Just read this, the blue slide I show you. Just read that slide in 2 or 3 minutes in front of her. Any allergies? May I know your BMI? May I know your blood group? Thanks for answering your question. You want me to add anything? This takes just 2 3 minutes. Please don't ever imagine to miss that. If you, for example, miss my family history, okay, let's talk about you miss my family history. I had cancer with my aunt. I have cancer like colon cancer in my family. What you will do? You miss a safety point, and they do this. They do this. You miss my blood group. I would say at the end I was O negative. You missed any reservation for blood transfusion. I was Jehovah's positive. What you will do? Just give 2 to 3 minutes and then rest 7 minutes. Let the patient ask. Hira, is it clear?
Yeah, thanks.
If you practice, you will know that it won't take much time. Won't take much time. Today, I was just like mimicking how to speak and how to do. Next time, like if I do an SPT with you guys, I won't need to tell you enter the cubicle. I'm sliding the investigation. We won't interrupt in a way so that it can be smooth and you can practice it easily. Who is next volunteer? You want to do it now or you want to do it next day? Tell me, guys. Is it boring?
I can do it, ma'am.
Who
Is
is the
it the
volunteer? Sorry, come
abdominal?
again.
Is it the abdominal pain?
Yes, Hira, it was you who told me that you will take
Yeah.
it. So why you are
Yeah,
worried?
yeah, yeah. No, I'm not worried.
Just come and
I
volunteer
will be
yourself.
fine. Yeah. I'm
So
going to.
you are starting it?
Yeah.
Okay.
Okay, Hira, you knew the long case format, right? You have 24 minutes, and examiner one will take will mark your history and examination, and examiner two will you have been asking the investigation from examiner two, and he will discuss the management part with you. and the patient will be silent after the history. If you keep on asking, like in the management part, if you come towards me and you ask me, sorry, I forgot to ask, I won't tell you here. Okay?
Okay.
Because at my time, even when I was done with my history, because this patient was a doctor from the hospital, we were performing our OSCE station. So she left the door. Her part was done. She left the door. I was proceeding
wow.
with the examination and all that. She left the door. Okay. So she is available for the history part only. So whatever comes in your mind, please make 4 walls with this patient. Whenever she goes, you can make the roof, door, and window later on. Okay.
Yeah, sure.
I will start the timer. Please give me a second. Dr. Hira, I want you to be an examiner, like because I would acting as a patient. Can we have a patient from participants so that we can mark Hira?
Oh, that would be great.
Okay, I can be your patient. It's fine. Start, Dr. Hira. You will also mark her. And the HERA candidate, please remember when you enter in the cubicle, you always have a paper and a pencil, and you need to use that paper and pencil for yourself. It's okay if you are like in your memory, you can remember all those relevant details, but it's better to write and then make a mark on these sites like risk factors. If I told you I'm previous to, you should notice that, right?
Sure.
Okay. 1, 2, 3, start.
Knock, knock. Hi, I'm Hira. I'm one of the candidates here. This is my exam code.
Proceed with your case, doctor.
Hello, I'm Dr. Amir. I'm one of the doctors here. I'm going to talk to you. May I know your name and age, please?
My name is Lily, and I'm 30 years.
Sorry, can you go it again? Lily, is that correct?
Yeah, Lily. Lily. My name is Lily, and I'm 30 years.
Okay, is it okay if I call you Lily?
Yeah, it's fine, doctor.
Okay. Thank you. And Lily, what do you do?
I'm a teacher by profession.
Great. And what brings you in today, Lily?
Doctor, I have pain in my tummy, and for 3 days. Initially, it was like severe pain, but now it's a little bit settled.
All right. And did it start suddenly or it built up gradually over the 3 days?
Initially, it was a little bit sudden, but then it was like stable. Like sometimes it starts. Right now, I'm talking with you. I'm feeling pain.
No, I'm so sorry. Are you okay to talk or you I need a glass of water?
No, doctor. I'm able to talk.
Okay, we'll finish it up quickly and we'll get on to what's going on with you. We'll go from there, okay?
Okay, doctor.
Okay, and how severe is the pain if you rate from 1 to 10? 1 being the least and 10 being the worst pain.
Doctor, it's like 5 by 10.
Okay, and where exactly in the tummy is the pain? Can you point for
You
me,
see here
please?
in the left side of my tummy here,
Left
near my
lower
pelvis
side
area,
or upper side? Okay,
lower side in my pelvis area.
and is it going anywhere else?
Sometimes I feel in the leg, but not really.
Okay, and you said it's coming and going, is that correct?
Yes, intermittent.
Okay, and
Please
what
mute
is the
your
type
mic.
of the pain? Can you tell me,
It's like,
could you describe your pain for me?
doctor, I told you it's like almost 5 by 10 in severity, and it
No,
comes and
the
it goes
type of the
away.
pain. Like, is it sharp? Is it dull? Is it achy? What type of a pain is it?
It's dull.
Okay. And what makes it better? Does it get better at all?
Painkillers.
Painkillers. What type of painkillers are you taking?
My GP gave me some painkillers and now she said me to go with you guys.
Okay. And does anything makes it worse?
I don't know, doctor. Bending can make it worse.
Bending makes it worse?
Yes.
Okay. Okay. No problem. Is it related to food? Is it
No,
related to
doctor.
food intake at all? Okay. And how's your appetite?
I feel nausea.
You're nauseated. Okay. And is it associated with any changes in your bowel movements?
No, doctor.
Okay. And any changes in your urine?
No, doctor.
Is it coming too often or too yellow? Is
No,
it
doctor.
painful? No?
No,
Okay.
doctor.
Okay. And what about any bleeding from down below?
No bleeding with this.
Mm, no bleeding. Any discharge,
No,
which is
doctor.
unusual? Okay,
No, doctor.
great. All right. Do you have any fever at all?
No, doctor.
Okay. And when was your last menstrual period date?
It was like 3 weeks before.
Okay. Any chance you're pregnant?
I'm not sure of it because I'm trying for pregnancy.
Right. Do you have regular periods in general?
Yes.
Okay. And how is the flow of your period? Like heavy, normal, bleeding during your pain during your cycle at all?
No, doctor.
Okay. And so you said you're trying to get pregnant, so I'm assuming no contraception, right?
Yes, doctor.
Okay. Thank you. And have you ever been pregnant before?
No, doctor.
Is it by choice or
Doctor, I'm in a relationship since 6 months, so I'm trying
okay,
for it.
all right. Great. And are you in a stable relationship, if I may ask?
Yes, doctor.
Okay. And have you taken any fertility treatments at all?
No, doctor. Do I need that?
Oh, you don't need that. It's just the usual question we ask.
Okay.
And when was the last pap smear you had?
I'm up to date, my smear.
Okay, great, lovely. And all right. How are you feeling with your pain? Sorry, I'm just gonna be very quick.
Doctor,
Is
I'm
there
feeling
any?
pain. I told you.
Yeah, I'm sorry. We'll be quick. Is there any pain while you pass the stool? While defecation, is there any pain at all?
Doctor, you asked me about my bowel work. It's fine.
Okay. Is there any medical condition that you have been going to your GP for?
Yes, doctor. I'm hypertensive and I'm on my medicines.
Okay. And are you on regular medication?
Yes, doctor. It's perfectly
Mm.
fine, and I'm with my follow-up with GP as well.
All right, lovely. And is there any surgeries in the past on your tummy or down below?
No, doctor.
Okay. And are you allergic to any medications?
No, doctor.
Okay. Is there any medical condition that runs in the family?
Doctor, my friend has appendectomy last night.
In the family?
No,
Okay. Any diseases related to the ovaries, the uterus, or
no,
the
doctor.
cervix? Okay. All right, I'm gonna ask you a few questions regarding your lifestyle, if that's okay. Do you
Yes,
smoke
doctor, you're
or
ready. Question, please
drink
proceed.
alcohol?
No, doctor.
Okay. Is there any specific diet that you're on?
No, doctor.
Okay. What's your height to weight ratio? If you would know.
25.
Okay. And all right. Is there anything else you want to add regarding
No,
your
doctor.
pain that I may have missed?
No, doctor.
All right. Lovely. So I would like to
Blood
proceed
group is O
to,
negative. I think you need that.
sorry.
My blood group is O negative, doctor.
Okay, thank you for telling me. I'll just mention that in your notes.
And I'm feeling so down today. I don't know. I have been feeling so down for the past few weeks.
All right. Okay, I'm gonna mention that in your notes, and in the end, I'm gonna ask my colleague to have a look at you and ask you a few more questions if needed, right?
Okay, doctor.
We'll take care of that, okay? Don't worry. So I would like to proceed with the examination, if that's okay.
Yes, doctor.
Please let me know
Okay,
whenever
so
you feel pain. I
now
will stop.
you do your examination, or just
Yeah.
demonstrate how you will perform your examination. Your command is do your examination.
Okay. So I will take the consent of the patient, obviously. I will sanitize my hands. I will go on the right side of the bed end of the patient. I will have the patient lie down comfortably in the bed. I will start with the general physical examination and we'll look for pallor, jaundice in the eyes and the mouth, the oral cavity, hygiene, the hydration status by looking at the buccal mucosa and the tongue, obviously.
Okay,
I would also look for any
uh,
ulcers.
do specific examination only. Specific examination only.
Okay. I would want to examine the abdomen. I will start by the inspection. I will go on the bed end, the foot end of the bed of the patient. If needed, I would first want to have the patient a good exposure, obviously with consent in the presence of a chaperone from xiphisternum. I want the exposure from xiphisternum up until the mid-thigh. I would go on the bed and foot end of the bed of the patient and look for any visible abdominal protrusion, visible scar marks, dilated veins, or swellings or possible hernias. And if needed, I would bend down to confirm my findings. Then I would come back again on the right side of the patient. And if needed, I would ask for a cuff reflex to see for hernial orifices. I would start with the superficial palpation, going through all the quadrants in the S shape. And I would keep looking in the eyes of the patient for pain as she is in constant pain. And I would ask her that please stop me whenever she feels uncomfortable and we'll discontinue the examination. Then I would proceed, if any positive, then I would proceed with the deep palpation, which would involve rebound and guarding for the signs of peritonitis, because at this point I'm thinking it's appendicitis. And we'll do the specific test like the source sign, and also the rebound in the left lower quadrant. What else? And then I would go for percussion. I would listen to the bowel sounds in
Do her
case there is.
gynecological examination. Do her gynecological examination.
Okay.
You already done with
Again,
the inspection and palpation. Do the gynae examination now.
okay. Now I would want the patient in the lethargic position. Again, I would want the full exposure, which would be
The exposure is done already.
tell me below.
The patient is
Sorry?
fine. Proceed.
Exposure is done. Okay.
Exposure is already
Then
done. Please proceed.
Okay, and then I will, of course, explain. I would start with the inspection of if there is any visible bleeding, discharge, or abnormal structural findings. I will just narrate that. Then I would want to do a speculum examination to look at the cervix, and I would explain the patient that it will be a cold touch, just deep breathing to avoid pain. And same when I'm taking out the speculum, then I'll do a digital examination. I'll check for the size of the uterus and also the adnexa for any fullness in case of ovarian cyst or pelvic appendix. And I would obviously keep looking at the
Okay, done.
patient's
Summarize your case.
facial expression.
Summarize your case.
So my case, Lily is 30 years old teacher. She presented with abdominal pain, which is episode intermittent for the last 3 days, getting severe, described as dull. 5 on 10, improved with painkillers, getting worse on bending only. It's not related to food. She had some nausea. No changes in bladder and bowel, and not associated with any bleeding or fever. Our last menstrual period, however, was 3 weeks ago. She was unsure of whether she was pregnant, but she was trying to conceive, and she was not on any contraceptives. In medical history, she is hypertensive but controlled on medication. She's not allergic to anything. Her blood group is B negative. On examination, I couldn't find any positive findings. That's it.
You're done. You're done. You're done. Hira, it was a very beautiful presentation.
Okay.
Now you have crossed 15 minutes. Obviously, with the practice, you can do it. You can finish this part in 12 minutes. So you only just
Right.
took 3 minutes ahead of your things. You want to
Right.
proceed with the investigation or management, or you want feedback of the history? Because I feel like I
No,
should
no,
give
let's do the history and examination so that we are in the flow, and then
yeah.
in the end,
It
whatever
will be
mistakes
easy. It will be easy.
yeah.
Okay.
Yeah.
So you missed the biggest part. You didn't set an agenda with me. You
Oh,
have to tell your patient in the 2 days I can see you are in the pain, you are here, whatever, Didi, whatever. Before to know the more details about you, I have to ask certain few questions. Then I would like to examine. Then we will offer certain investigation, and I will discuss a safe management plan for you. I'll give you information leaflet. I'll book your appointment with my consultant if needed. Are you okay with this
right.
plan? Okay.
Sure.
Agenda was missing. Agenda was missing. See, okay. The next thing, you dig in the pain too much.
Okay.
Scoring. You asked me type of pain. I am not doctor. I don't know the types of the pain, dull, character. It's not my OBGYN. There's no need to ask the type of the pain. You just simply say how
Okay.
you define your pain. This is one character. Scoring. Okay, that's fine. Even you ask, I told you the pain relieves with the painkiller. You asked me the types of the painkiller. Your patient is in outdoor. She is not having IV painkiller. She is not having any IV line save on her. There's no need to ask the types of the painkiller. I knew you have been so perfect, but you don't have so much time. Please. Too much digging
Yeah.
into the pain was not necessary. You asked me the relationship of the pain with the food. There's no need. You simply ask, apart from the pain, do you have anything else? Oh, look, come back to the pain. I told you I am having the pain right now. You offered me water. Why you didn't ask me, is it the pain you are able to talk? You want me to stop? You want me to give you a painkiller? I
No,
can
I
do
think I
that.
said that. Are you okay to talk?
Yeah, you
I
asked
just
me,
said that.
but instead of offering water, you can ask if the patient is in the pain, address her pain right now. You want me to give you painkillers?
Give you
I can
painkillers.
ask my
Okay.
staff
Okay.
to do it for you. I can
Yeah.
ask,
Yeah.
are you
Sure. Sure.
comfortable to talk? Should we proceed? Okay, thank you. I know you are in the pain, so I would like to be you address that part. That was okay. So you ask the bowel work in the start, any problem with the bowel work? Then again, you asked about the defecation. There was no need. The urine, you asked me about the details of the any problem with my water was, that was fine. But then you asked the color of the pee, character of the pee. If I said no, it means no. No need to ask.
Okay. Right.
Then suddenly in this, after you suddenly ask any bleeding from down below. But what does
Yeah,
it
because
mean?
that's one of the associated symptoms, right? It could
Okay,
be.
you can ask any vaginal discharge or bleeding down below with the pain. Okay, it covers your both part. I know you can be thinking of PID, you can be thinking anything else. It can be endometriosis, whatever. We don't know the
Yeah.
why she's. It can be
Yeah.
ectopic. Yes, you have to
Right.
rule out the spotting. So you can do it in one line: vaginal discharge or vaginal bleeding. You asked when was your last period? 3 weeks ago. She was trying to become a pregnant. Then you said, okay, it's mean you are not using contraception. And then coming to your examination, you to even in your summary you mentioned again she is not practicing any contraception. Forget about. There's no need to tell any negative thing. All the negative points. You just
Okay.
simply say patient is trying to conceive. She
Okay.
missed her periods 3 weeks ago. So
Mhm.
you
Okay.
ask the detail about the flow of my periods, pain in the cycle. No need. Just simply ask
Okay.
your periods are regular. Any complications in that? Simple one-liner. So pain,
Right.
the pain part was too much. You missed the my favorite part, the family part, and you asked about my friends. So if you will
No,
remember
I
the
asked
question.
about your family. I didn't ask about your friends. It was
Okay,
family.
what I perceive like friends and family.
No, why would ask friends and
Yeah,
family?
that's
No,
fine.
no,
That's
no,
fine.
no.
That's perfectly fine. Okay.
No, no,
So you
you
missed.
said my friend has this, so I said I asked your family.
Yeah,
Sorry,
yeah,
maybe
yeah.
it was just a voice break.
I knew you have
Yeah.
been there. Okay, so the other thing coming to you, why you asked me I'm on the fertility treatment or not?
Yeah, I shouldn't have because you were only married for
You
six
don't
months.
have
I
it.
was
two
just trying
years.
to rule out all
Yeah,
the
yeah,
causes of
yeah. So
abdominal
again,
pain.
here,
Okay.
here again, you came with the pain. I don't know what question you asked me. I have written the pain again. So here you asked something question about the pain again. I was fed up because you didn't offer me the painkillers. If you have been seeing my face,
Oh,
I
I'm
was
so
fed up
sorry.
again. So you
I'm
again
so
asked the
sorry.
stool question here. There was no need. Medical, you done it very right. You simply say she was asking you, okay, I'm controlled hypertensive, that's fine. Surgical history, you asked beautifully. Allergies, you rule out beautifully. Friends question, okay, you didn't ask, but I assume that, okay, that's fine. When you asked about my family history, I said no significant history. But you again asked the ovarian cancer or the womb or whatever. Please trust me. I am telling you no.
Okay.
Go to my family. Trust me. You asked
Okay.
the
Okay.
alcohol smoking, that was fine. You missed the mental part, mental history. You missed that.
Yeah,
So
I
I told,
realized when you said.
I told myself so that you could
Yeah.
remember.
Hmm.
You missed my
Yeah.
blood group. I told O negative. If you
Yeah.
ask me, I would be O positive. But since you missed, so I was trying to give you a clue that you missed a major part.
Sure. Sure.
Listen,
Yeah.
whenever
Yeah.
a patient reveals like I'm feeling down or depressed, please, 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 this is a medical emergency. This is very serious thing. You can never say, I will, all right, is it, you asked me to contact with another doctor, but here you can say, are you able to talk me? I'm so sorry about that. We would like you to
Hmm.
connect with the counselor. We would like you to connect with the sport group. I would book an appointment with the psychologist for you today. Should we proceed? Please, please, please address there and then. If I have been
Okay.
smoker, what would you do? Okay, I told you I'm a smoker. What will you do? I'm a smoker,
Um,
doctor.
yeah. So then I will say that, are you interested in quitting smoking?
Yeah, yeah. That's
And then
fine.
she
Then
would ask,
there and then in
yeah,
long case. In long case,
yeah.
address there and then you sell.
Hmm.
Then you say I will book an appointment with like
Yeah.
that smoking quitting programs. I can provide
Yeah.
you the all information. Okay.
Yeah.
So here
Hmm.
the
Yeah.
counselor part was missing. That was a big, big, big red flag sign in your history. You did the general physical examination so perfectly, but you will tell me what mistake you have done. I will show you one slide back for you here.
I'm sorry, your voice is breaking. Come again?
Am I audible?
I did a...
Am
Yeah,
I
now.
audible?
Yeah, yeah.
Okay. Hira, you in examination you missed this part.
Which one? Which one?
Can you see my arrow?
Oh, bladder. Oh my God.
You did not ask me to empty my bladder.
Okay. Sorry. I should have done that
Okay.
when you said the
And
gynecological
the other
exam.
thing, you ask, I will look for the patient face, but you forget to mention, since my patient has the pain in left side of her tummy, I would examine that part or I would palpate that part at the end, looking at the face of my
Yeah,
patient.
I didn't say that, but I just mentioned that I'll keep on
Take
looking
the
at the
pain very
face.
seriously. Patient becomes offended. Take the pain very seriously. Offer painkillers. Touch their painful
Can
part
you
at
mute
the
yourself? Who is this?
आगे ले आए हो कि नहीं?
Dr. Hira, please mute this lady.
Okay,
Who
I
is
have
this?
muted.
ले
Sara.
आए कि नहीं?
कोई बात नहीं, it's okay.
Hira,
मेरे
Hira,
लिए भी
the
ले आए पकौड़े.
examination is in the dorsal position. You don't took the patient in the delivery room and make a pole and make a lithotomy position for her. The lithotomy
The
position is not.
gynecological examination?
Yeah. Lithotomy.
I did say that.
Position? You know what is lithotomy position? You hyperflex the calves. You put the poles. That's the lithotomy position. Simple dorsal position.
Okay.
Don't use the word lithotomy. Don't use the word lithotomy.
No, yeah, that's aggressive.
Dorsal position is
Okay.
fine. You forget
Okay.
to lubricate the speculum. You did it very well. Even
You were
told
really looking at my mistakes, huh? Okay,
Yeah,
good.
I was marking because I'm your examiner. I told you the examiner is silent.
Yes.
I had to do two parts like history. That's why I want, if someone else was giving you history, I would point out more mistakes. Trust me.
No, it's actually nice. You if you know your
Okay,
mistakes now.
lubrication part you miss, and you obviously you signpost me. You told me it will be cold to touch, but you need to signpost me for the vaginal examination. Like it will be little bit uncomfortable or painful, but I will be gentle doing that. Okay, signpost is needed more.
Mhm.
You summarize your history beautifully, and we will learn like when you will practice more, you will learn how to say like in one words or two or three lines maximum. The
Okay.
rest, it was very nice presentation. Passing. Examiner one,
Great.
passing. Okay, now proceed towards your investigation.
Excuse me, doctor. May I ask
Yeah.
a question?
Yes, Asra.
Doctor, you said the summary, but the summary is not like that, which we present in our FCPS, that there is, it should be before the summary, we have to ask about, kindly give me the examination part or like that? Or we have
Asra,
to
here,
proceed the summary
I guess you
will be
missed the
complete.
starting part. I told you when you done with your history, the examiner gives you a command. General physical examination, they don't ask, they give you command to do the gynecological examination. For example, in gynecological examination, you do the inspection, you do the per speculum, and you do the per vaginal examination. So here I did what we do the examination on the dummy. If there has been a positive finding, for example, it has been a cyst, palpable cyst. It just as simple as like you put a ball under your pillow casing, the ball must be palpable. So the dummy already had that finding. This is not you are talking, this you are performing. Examiner will stand with you. You will perform the real examination on the dummy. You will do all the steps. You will ask your dummy to empty the bladder. You will maintain her privacy. You will ask for the presence of the saffron. You will stand on the right side. You have to enumerate every step. So if examiner wants to incorporate a positive finding, examiner will put a positive finding. If there is no, for example, in my case, there was no positive finding. So I told her on inspection, on per speculum examination and per vaginal examination, I could not find any clue. Or I can say the examination were unremarkable. Is it clear, Asra?
Okay, doctor, one thing I want to ask, if there is a some positive finding on the examination, say for example
Yeah.
a mass is there, so
Okay.
like that we have to examine the mass with the inch tape or by the 22-week
Yes,
size
yes.
or all that
You
we
will
have to do like this.
yes, everything. If they put a ball in a like a dummy, you will feel a ball like structure. For example, you have to do all the its consistency, surface to touch, attachment with underlying skin, mobility, temperature, consistency, everything you do that. If they
Okay,
don't put a
so
mass,
regarding the
please
summary, okay,
examination
okay,
of
I
mass.
got this. Okay, in her case,
Asra?
she has to, yes.
Asra? Can I answer Dr. Saba her query?
Yes, ma'am. Yes, yes, yes.
Okay, just hold on. So here is actually, I prepared this slide not for today's session, but my plan was that to discuss it in the next session. But I think Asra asked this slide now, so I could answer right away. Just 1 minute. Okay. So can you see Asra this slide?
Yes.
Dr. Hira, we cannot see. I guess I have to stop sharing.
No. They will check it sooner. Now check.
I can see.
And
Okay.
me too.
So Asra, you were asking how to actually do examination. So in exam, they will provide you a mannequin, as Dr. Saba told you, and there will be something positive, and you have to mention it. Because, like on general inspection, there will be some scar. You will mention it. On palpation, they will give you a mass, and it will be like a ball, right? And it will be actually like that, not on a real patient, on a dummy you will see. Rather, you will feel. So you have to mention side, size, shape, surface, borders, consistency, tenderness, mobility, and everything the way you do actually on a live patient, right? So in coming up
Okay,
sessions, we will provide you a template or checklist for each and every examination, like how to do abdominal examination in OBS patient, gynae patient, with mass, with prolapse, how to do actually speculum examination, everything, in a standard way. So nothing to worry. So Dr. Sabha, you can continue your session. Apology for interrupting.
It's okay. Are you clear? Are you clear with your question?
yes, doctor,
Asra?
thank you so much.
Yeah, we will actually we have a plan to keep a session for examination only. How to do the perfect examination. Even if you don't have any finding, how to proceed. If you have any finding, then how to proceed. We will do all these steps. Ideal examination. Okay, don't worry. So for the feedback part, coming back to our candidate Hira, we mentioned the biggest flaw was like 15 minutes. You took 15 minutes for the history. If next time you practice like one liner, don't go much details. Like no need to ask the periods detail, pain detail so much, and trust your patient. If you say there is no problem with her waterworks, trust her. So you will save your time. Okay.
Sure.
Now, come to second part, investigations. By the way, you guys have to wear your watch and you have to practice with that. There is no stopwatch in your station. I'm starting your time. Kira?
Yeah. So I'd like to order some investigations. Can you hear me?
Your examiner is sitting in front of you. You are turning towards the examiner too. So start your case, please.
Yes, I would like to order some investigations. So then you will ask which investigations? Or I just have to keep on going. I would like to order a complete blood count, urine and electrolytes, complete urine examination. I would like to do a beta HCG to rule out pregnancy, a pelvic ultrasonography.
Okay, wait, Hira, step by step. You asked me complete blood count. What you want in complete blood count? Tell me.
I
You have
want
to
to
tell
look
me
at,
whatever you will ask, I will provide you that. Okay.
okay, I would do a complete blood count and look at the hemoglobin and WBC.
Hemoglobin is 11 gram per deciliter, and white blood cell count is normal.
Okay, and I would like to do urine electrolytes.
Why you need that?
Just to see the hydration status. She was
She's well
nauseated, maybe
hydrated.
she's
Even you
eating
offer
more.
water
Okay,
in your clinic. She's
that's
well
fine.
hydrated.
Okay,
You still need that?
fine. Done. No, thanks. Yes, I do need that. Maybe we have to plan a
Okay.
surgery.
You can
I don't know.
yeah, you can order.
Okay, and then I would need a complete urine examination as well, just to see if there is asymptomatic urine infection.
What you need in your complete urine examination?
I
What
want
you
to
need
see
for
nitrates and leukocytes
not
and
present,
RBCs in
not
blood.
present.
Okay, I want to do beta HCG or urine pregnancy test, whatever is available and fast.
What you need? You need both or
I want
one?
to confirm. I want beta HCG.
Beta HCG is not done, however, urine pregnancy test is negative.
Okay. All right. Then I would want to order a pelvic ultrasound,
Okay.
abdominal pelvic ultrasound,
Abdominal
just to look
pelvic.
at the size of the ovaries and also to look at the appendix if at all possible, and possibility of renal stones.
I don't have abdominal pelvic ultrasound. I only have transvaginal ultrasound. Will it will work for you?
Sure.
What you want in that?
I want to look at the adnexal structures, the uterus and
Okay.
uterus
We
and
have a
adnexa.
transvaginal ultrasound in which there is 8 into 7 centimeter simple cyst in her left ovary. Rest of the scan is unremarkable.
Okay. I would also, can I go back to the blood group and cross match as well? I want to do
Your
in
patient
case we
didn't
were
told you her blood group? What was her blood group you had with you?
O negative. Yeah.
So you
O
want to
negative.
reconfirm her blood group and RH factor, right? It's O
Yeah.
negative.
Thanks. All right. So
You need anything else?
I need anything else. In terms of the investigations, is the
Doctor, I'm
renal
here.
function and LF?
Whatever you,
Hello?
whatever.
Hello?
Yes, Hira.
Yeah. I may want to order the renal function test and LFTs just
Why
to
you want
prepare
for the
her,
renal function test?
just to prepare her for surgery
Okay.
as baseline. Yeah. If this cyst is 8 into 7 centimeter, it's over the cutoff for the conservative management. So I would like to do an anesthesia consult as well, involve my seniors and explain my findings and discuss the case for removal, as this big cyst can turn into torsion as well.
Again,
And
what
she's
is your
already
management?
nauseous. Sorry. So I would like to go for the surgical management, as the size of the how the cyst is simple. However, the size of the cyst is too large to end up in a torsion. And
How would you do that? What is the name of your surgery?
I would do a laparoscopic ovarian
आप
cystectomy.
ये ना बेटा
Well
Sorry.
done. Now,
बेटा इधर
I
मेरी
would want to get
how
can
you will proceed?
okay. We would like to first of all do the anesthesia fitness, and I would like to discuss this case with my consultant as well, and
Perfect.
we will involve the patient as well. We will explain why we are doing this surgery, what type of surgery is it, what are the complications, and follow-up of this
Okay,
surgery.
Dr.
with the
Hira, can you tell me, Dr. Hira, can your patient be managed conservatively? How you will counsel her for surgery?
So we can actually tell her that if she would really insist on conservative, then we will tell her why are we not going for conservative management, because this is a size bigger, which can cause the ovary to twist on this cyst, and which would cause the ovary to actually die, which can affect in future the fertility, and the management can be more intense. And so we can counsel her regarding the risk. Sorry?
Fine, you have done her cystectomy, you counsel your patient, laparoscopic cystectomy is decided. Anything else you want to manage her? Anything else in her management?
She wants to be she was trying to become pregnant as well. So we can follow her up in the 6 weeks time, but we will tell her to
Like
do we
you
tell her
will
to
you will keep a follow-up, right? You will keep a follow-up,
yes,
right? Okay,
yeah.
next, anything else?
Anything else?
You're done with your station, your time's up, but I want you to add anything else.
Add anything else for this patient? Oh, was
Yeah,
she
for your
30 years
patient.
old?
You are making a
we
window,
will,
right?
yeah, we will just keep following her up on 2 agendas. One is
Okay.
the cyst doesn't come back. The second
Okay.
is we'll send the report of we'll send it for
Histopathology done, follow-up done, fertility consultation done. Anything else?
What else? Just the recurrence, follow her up for recurrence.
Okay,
Nothing
you
else.
told me recurrence. Anything else?
No, fertility, that's it.
Okay.
No?
You discharge her. She committed
Yeah,
a suicide.
discharge her.
She committed a suicide.
Oh my God. Sorry. Yeah.
You are making unless
Sorry. Yeah.
making window
No.
for your room. You forget patient has mental illness. Her blood group was O negative.
Yeah.
Why you ask me if you don't have any intention to address in the management? It's not the case, by the way. I'm using these words just to emphasize, just to make you remember whatever
Okay,
you
yeah,
ask,
no. These
whatever the
things are
positive
important.
finding or risk factor, it has a significance while you manage your patient. The way, okay, for this part you are pass again. Well done, very well done. In fact, you ask the complete blood count. I love that, but you need to ask complete. May I have complete blood count with date, including hemoglobin gram per deciliter, white blood cell. No, don't say WBC.
Oh, okay.
You are working in Ireland. You are talking with an Ireland consultant. You are MRCPI consultant now. What is WBC?
Sure.
Why you were so enthusiastic about my hydration status and you ask urea and electrolyte? Like you forget. Let me tell you, we have like two types of investigation: general and
Yeah,
specific.
the focus and yeah.
Yeah.
But
So
I
general
think
investigation.
so how do we start? Like, do we start with specific?
No,
'Cause
listen. You always start with the general health profile. You ask complete
yeah.
blood count, like the way I
Yeah.
asked with the date. You always ask the date with the hemoglobin gram
Okay.
per deciliter, white blood cells count, platelets count. Okay, you ask this. Next, you ask complete urine examination. Next, you may reconfirm her blood group with RH factor. And again, if the patient is pregnant, you will ask her booking investigations like torch profile, chickenpox, rubella, and all that. Here, your patient is not pregnant, it's not the obstetric case. So from here, you will shift towards the specific investigation. Number one investigation I wanted to listen in the specific investigation is the urine pregnancy test or beta HCG, but don't ask both together. Since you complicated, so I was trying to complicate it for you. You can simply ask, I want to check pregnancy status. Do we have urine pregnancy test or beta HCG or any test? They may have done the ultrasound and there's ectopic showing ultrasound. They may have done. You never know. So you just exclude the pregnancy, tell the investigation and tell the reasoning to ask for. If the examiner asks why you are so much interested in the complete urine count or CBC, you simply say it's the general health profile of my patient. I want to be aware of that. Okay. So again, you forgot the room picture. You remember the room picture? You was putting a garage door on my poor room. This was very small room, but you ask a big investigation, urea and electrolytes, renal function test. Oh my God, what happened? You were not trusting me. I told you I'm okay. My water work is okay, but still you had doubt on me. Still you ordered renal function test.
Because I wanted to operate on you.
That's what you were doing. That's this doctor. Where is that picture? The MRCPI candidate doctor. She was trying to do the myomectomy on this patient. I will run away. She was trying to do the myomectomy. You did the same. Okay. Ultrasound. Hira, there's a tip for you. If you palpate the cyst in palpation, if you had palpate the cyst, then you can ask abdominopelvic ultrasound. If you have not palpate the cyst, there is no findings. Always ask for sexually active patient. Always ask transvaginal ultrasound.
Right. Okay.
Okay. Transvaginal ultrasound, then command your examiner what you want in that. He is not your like buddy sitting over there. You have to ask for the lining of the womb, status of the myometrium, for ovaries, like you ask beautifully. You ask beautifully. I'm just making like more polish for you enough it.
Sure.
I told you 8 into 7 centimeter. I love that you did not ask for MRI. I love that you did not ask the tumor markers.
It was a simple cyst. No. It was a simple cyst.
Yes. That's what you presented, like you made the door only specific to that room. That was a positive point. I love that. And then you suddenly you said, okay, here you say your examiner, when I told you the cyst, you say, I'm done with the investigation. Now I want to proceed for the management plan. You tell your examiner, like, please close this file, proceed to the next section. Here in the management plan, you can say, like you can start up, I would address pain of my patient on the first site. I will counsel her about her diagnosis. What is the cyst? What is the nature of the cyst? I can tell my patient there are 3 ways of management. Always remember this: conservative, medical, and surgical. But for my patient, since she's a teacher by profession, everything you ask, please address in the management. Since my patient was a teacher by profession, it was interrupting her quality of life. She was feeling mentally down. So I want an immediate relief for her. I won't put her on conservative management. Our medication has helped her only the pain part, but since the cyst size is already more than the cutoff, so I would like to proceed for the surgical management, in which I would like to do the laparoscopic cystectomy. But before embarking on that, I would like to involve your communication with the colleague was missing. You did not. You said
I didn't.
Listen. You said I will take the anesthesia fitness, but here you should say you involve the consultant. I love that. But here you can say I will involve the team of doctors with me, or multidisciplinary approach in which the counselor, the medical, mental health team, I will take them on board. Mental health nurse will be taking care of this patient like she's admitted with the depression. I would like to involve anesthetic colleagues. I would like to involve my consultant. You need to enumerate all these parts. You did involvement of the consultant, but don't say anesthesia fitness. Say I would like to involve the anesthesia department, okay?
Yeah.
And there's no need for doing the renal function test for the fitness. It's anesthesia job in the Ireland. They will do that. You don't need to do that.
Okay. Yeah, I got confused because when I saw the cyst tag, that's why I was
So
going back to
communication
the.
part was missing, safety point was missing. You did not address the mental health. There was a red flag sign. Rest investigation, you asked beautifully. Okay, I was coming towards the management. For the management part, like you did the surgical management, and you told you did not you could have been mentioning the like after laparoscopic cystectomy, we will mobilize the patient, we will take care of her VTE prophylaxis.
We have to say
will,
that too?
yeah. If the examiner is silent and he's giving you time and you are left with the time, then you have to say all that early mobilization, early.
Yeah, because I wasn't sure
fluid
how to.
intake.
To be very honest, I wasn't sure how to proceed with the management. Either there would be prompts from the examiner or not, or it's just only me, blah blah blah. And then only the examiner would ask me whatever he wants, me to help me or something
It's
to
only
direct me somewhere.
in the management part. In the management part, if the examiner is silent, tell all you know. Keep on speaking until he interrupts you.
Okay.
In the management part only,
Okay.
in the management, but not with the patient.
Okay.
Don't speak, continue to speak with the patient. Let the patient speak. For the examiner, if the examiner is silent, you continue. If the examiner is asking you, you want anything else or you want to add in your management, it means he has already passed you. He just wants you score higher. I was asking you again and again to address mental illness and O negative, you missed that. For asking the multidisciplinary team, did you ask for
Yeah,
me
I
and
missed
Jehovah's
the.
positive or not?
No.
No, you missed that. Okay, this is the safety point you miss of the patient. So you rest beautifully, you give me information leaflet, you ask me for the follow-up, for the stitch removal, usually it is dissolvable, it will be self-dissolvable stitch, you address my pregnancy, fertility concern. You could have asked me in the mental team and all that, and rest, everything was perfect. I love your station. You're a past candidate today. Here the simple, you see the medical, whatever management you have, you always say conservative medical surgical. Since my patient is beyond of this, you well wisher of your patient. You just become like, she's a teacher, she's suffering, I want to help her. Okay, medical, she's already taking medicines. Surgical, you have to address the name of the surgery. They won't ask the procedure, they won't ask anything else. They will just ask how you admit, how you do, name of procedure, what is post-op follow-up, what is the complication of the procedure. They are interested in this part only. And all the areas of the patient, all the safety areas, all the checklists you have to tell. That's it.
Okay.
Any question? So you are ready to be an MRCPI consultant?
Made a better score with you, inshallah.
Yeah, inshallah. Any question, guys? Any difficulty?
Doctor, I want to ask what the basic profile we have to order. Only the CBC and blood group and RH factor? No renal profile, no
Astra, from
LFTs.
now onward, please don't say CBC.
Yes, complete
Make
blood
your
count.
practice. Yeah. Make it practice. We have to ask complete blood count, blood group with RH factor, complete urine count. We need to tell for any positive finding, like she told leukocytes, red blood cells. Complete urine count. If your patient is obstetric patient, you ask the booking investigation, torch profile, syphilis, hepatitis B, C. In Ireland, we do hepatitis C as well. In Ireland, it's a routine investigation. You ask HIV, sexual shared infection. That's all the booking profile. We say it booking profile. And you will ask the ultrasound, the booking ultrasound for confirmation of the date and anomaly scan. For example, your patient is on 32 week. So you will go back, you will ask anomaly scan for any significant anomalies and booking ultrasound for correlation with the dates. That's it. And for specific, you ask according to your case.
Okay, doctor.
Are you clear? I guess Dr. Hira told this question last time. She wrote the set of investigation in her last session.
Yeah,
Yes,
she
it
told
was
about
an obstetrical, but in the gynae, we usually order the renal function test and LFTs. That's why I'm
No,
asking,
no.
and
Here
the
you
Dr.
don't.
Hira has also asked.
You don't ask. Renal function test, no need. Liver function test, no need, please. No need of ECG. Nothing. If the patient is cardiac, then you send them to the cardiac department. You don't do these things. Okay? If
Dr.
okay, let me
Saba,
put you another way. If Hira can have said this, the patient is, since my patient is hypertensive, for example, that's why I want to do the renal function test. It will be acceptable for me. Whatever you ask, you give the reasoning, right reasoning. Don't tell me you want to check the hydration status. Come on, you can check she is dehydrated or not. Okay? So you can ask the investigation with the proper reasoning. If you have reasoning, they won't ask anything else.
Hello, ma'am. Sarah here. I want to ask a question.
Yes, Sarah.
Ma'am, actually, I want to ask that as there is no timer, I think, on the table. So,
Yes.
how we will practice and how we will come to know that how many minutes have been passed, and how we will come to know what's the solution for it. Please guide.
Part, like for practice part, you make your recordings. You in WhatsApp do with your friends, do in your groups. You do it with the stopwatch in the start. But the moment you try to speak, you will be knowing, okay, it's 8 minutes. I have finished this station. I know I can finish the SPT in 8 minutes. For me, and you wear your watch in examination. Apple Watch, iWatches, they are banned. Only simple watch you can wear for your examination, and you look into that as well. You mark your time looking at your watch as well. But don't look too much. The examiner know you are nervous. Don't look in too much. With the practice, you will finish your station. For me, I told you, at every station, I was sitting and I was asking, ma'am, you want me to ask anything else? In the structured discussion, she said, no, you are done. I have finished my question. You are done. Every station, I was left with the 2 or 3 minutes. It's just practice, practice, practice. Remember that the blue slide, I can't emphasize more. Remember the room structure, patient safety room. You build a room. Please, please, please don't leave your history. If you miss blood group, if you miss allergy, examiner will mark you like this is negative scoring actually. They won't let you pass the case easily. They will interrupt you. But if you make the history perfect, examination perfect, investigation up and down acceptable, management up and down acceptable. But for the history and management, they won't compromise. Am I clear?
Yes, exactly, Dr. Saba. You are right. And actually, majority students have done FCPS, so they already know the importance of history. Isn't it, Sarah?
Yes, ma'am. Very right.
So history will define everything because only history you can make a correct diagnosis. And when you are not
Yes,
making a correct diagnosis, so what about the management, right? So make your room, make your walls first, and then think about the other thing. Thank you, Dr. Saba. And anything else you want to add in this case feedback? Dr. Saba?
Dr. Hira, just simple like we will this obstetrical case, then I would like to add more points. This long case is just I want you to make like number one, they should take care of their time. This is time bound exam. What if they tell the only one question and they waste their 10 minutes and they leave the station, the bell rings, there is no purpose of speaking so much nice or so much words and so much explanations. So practice should be
Exactly.
time bound. Number two, they should keep the format in their mind. SPT, they have to answer the questions of the patient. Don't try to talk with the examiner at all. Examiner mind this actually. And for the long case, again, take the history completely. The Hira take a U-turn. I mentioned here she was asking me ultrasound, then she went back to ask for the blood group. So don't take U-turns. Always do the blood investigation first, then ask the imaging investigation like ultrasound. there should be a sequence. Always speak. The examiner is your senior colleague. So speak with the respect, complete words. Don't use abbreviations. Don't use WBC, CBC, these terms. And whatever you want. If I have been in her place, I can ask MRI, but my reasoning will be different. I can say I want to be this because my patient is having again and again pain. I want to check like torture, whatever story I can build, but revolving around the patient. The reasoning should be your patient benefit, not just you are like keen of ordering more and more investigation. In fact, I asked her for urea and electrolyte. Would you order? She said again, yes, I would like to order.
No,
So
I said I would like to order because I'm going to do a surgery for this patient. That's
yeah,
why.
yeah,
First,
yeah,
I said
yeah,
for the
yeah.
hydration status, and then we
Whatever the
need urea electrolytes for surgery. Maybe renal
you
function
don't need
test we don't.
you don't need it for surgery. Here
Usually, we don't
you
need
don't
it for
have to give the
surgery.
anesthesia. Okay.
Sorry?
So it was beautiful station, Hira. You are a passing candidate and you will shine bright, inshallah.
Inshallah. I have also very high hopes from Hira. It was a very good discussion, Dr. Saba, and we really enjoyed it. And I am hopeful you all enjoyed today's session and found it helpful for your OSCE preparation. So, you want to add anything? You want to say something?
No, ma'am. Only the candidates they can give us feedback how they find this
Actually,
session
I'm
and what.
talking to the candidates. So if they want to say something or want to add anything.
Monia, Hira.
Okay.
Rest I can't tell the names, iPhone and so many devices.
Okay, so before we close, I want to share something important with you guys. We are actually via MedHome platform are going to launch our comprehensive OSCE course, and it's now open, luckily. So those who are interested and those who want full guided program, especially for FAB 2026 attempt, if they're interested, they can approach us. So in this course, you will have a live interactive Zoom session with Dr. Saba, Dr. Amber, and a few cases with me as well. And there will be daily study support on Telegram. And apart from these interactive sessions, which will be twice weekly, there will be few sessions, probably 4 to 5 times a week on Telegram as well. Means that you will be provided a task, you will read it, and the volunteers will be given slot and they will record their feedback or their response in one audio. And the audio too will be the time bound. You are supposed to actually record in 10 minutes, and you will actually share it on Telegram in our study group, and the mentors will listen it and will provide you the feedback. So this is the way we will actually stay interactive on Zoom and on Telegram, right? And the course duration will be 3 months. And it's an ideal program if you are planning for Fab or May. I think so majority are planning for Fab and May. Very less candidates are being provided with November exam slots, isn't it? If anyone among you is actually selected for November attempt, also for November examinees, we are planning a mock exam. If they're interested, they can actually book us, and they can book their mock with Dr. Saba as well. So it's up to you if you are planning for November. So thank you for all your energy and focus today. Keep going strong, and this is all that. Actually, there is a one station left. So if you have, if you're interested, we can plan it, or we can defer it in next session. Any query regarding mock, regarding the
Doctor,
case?
I'm interested. I have prepared this
Oh, okay,
primary
okay, okay.
amenorrhea for you.
Okay. So,
If you
Dr.
have
Sabha,
time, if you have no
no, I
concern,
have a
then
lot of time. No worries, Asra. So I just was actually discussing the course things because many queries regarding the
And doctor,
course.
I also want to ask a question. This course will be
Yes. You will have access till Feb.
the
And
course will be started from the October or from the November.
no, we will start it from next week. Today's session was the last trial session. Now you know your faculty very well, Dr. Saba, me, Dr. Ambar, and actually we should start now. This is the right time. We will start from next week. Those who will actually subscribe the course, we will provide them with the planner, and we will go with planner. And Dr. Saba, what's your take? 2 sessions per week we have planned.
Yes, Dr. Hira. But we can modify according to their demand, like the way they want to study, we can modify that.
We
But
can
for the
modify it
time
in
of
3.
discussion, we will
We
post
can
like
modify it in
3 or
long. Yes, yes. As per candidates actually response, we can modify it. But the aim will be to complete the syllabus, because the name is comprehensive course. So it's mean there will be not only syllabus compilation, there will be recalls integration as well. You don't have to actually think about another crash course or fast track if you are opting this comprehensive program. So again, I am telling you comprehensive, it's comprehensive. 2 times per week sessions are minimal, and 4 days a week on Telegram interactive sessions. And probably in 3 months, if you are planning for FAB, we will complete all our tasks. So, and one thing more, we will give you the study sources as well. Like you will have ebook for your Irish guidelines, and apart from Irish guidelines, you will have module wise other guidelines as well, which you have to do, like NICE, TOG, FSRS, BASH, FIGO. And apart from this, the best thing in our course will be that you will have OSCE book with ideal stations, and they will be the recall stations. So in your free time, you can actually read the keys as well. But the main thing is that is not about study material. It's about how you are performing, how you are practicing, as the Dr. Saba told you people. The more you practice, the more you will learn. And actually probability to pass the exam will raise. So coming up on actually fee, if you are Medhome student, there is a discount. Otherwise, standard fee will be for this comprehensive course will be $300. And if no query on this program, we can continue with our structured discussion.
And ma'am, what will be the discounted if already who are added
Yes,
with you?
yes, Medhome students have discount. I mentioned you will not pay 300 USD. You will pay 250 USD for this comprehensive package.
Okay.
And
Okay,
Dr.
ma'am.
Saba actually was, Dr. Saba is also my student. She was very shining student in my actually FCPS program. And she's very generous and as well. And she want to actually teach Medhome students, and actually those students who are planning for November, free for their mock. If they're interested, she will take their mock actually totally free. So it's I again cross-checked it with Dr. Saba, and she said, yes, doctor, why not? Because this is a time to pay back.
until they are ready, until they are like serious
Ma'am, if you
candidates.
don't mind,
Serious candidates.
excuse
Yes,
me,
yes.
ma'am, if you don't mind, because I don't get time to interact with you, I just wanted to ask you one question. Ma'am,
Mm-hmm.
as I have given in the first attempt this MRCPI, this one theory, and I passed, Alhamdulillah. And I
Mm-hmm.
am also applying for MCPS theory now. So I
Mm-hmm.
wanted to ask you what I do. I
Do
should go
one thing,
for
man.
this.
No
Yeah,
multitasking. A lot of
yeah,
students ask me, we plan multiple exam together. So
yeah.
for majority students, I will not suggest to apply to go for 2 exams together. One exam
So,
should be priority. So if you have passed
uh,
MRCPI theory, I think you should
hmm.
actually wind up this program. You should appear in OSCE and pass it, then think about MCPS. It will be a better plan.
uh, Okay, ma'am, then what I do, because already I paid you for MCPS, so now you guide me, please. Because I have for the
Okay.
fast track also and for theory, and I want to, I have,
No,
yeah,
listen. Your MCPS is in FAB, and your
yeah.
MRCPI OSCE is also in FAB.
So,
So
ma'am,
you
in the
can.
FAB OSCE, we don't know either I will get in the FAB this one seat, or
Okay.
maybe in May, maybe in November.
So ideal advice will be that prepare then to
Mm.
actually both things together. But once your
Mm.
booking will confirm, then stick to one plan, and that should be your OSCE.
Okay. Even
Because
when it is confirmed.
once confirmed. because
Okay, ma'am.
you will lose MCPS as well and OSCE as well, and
Yeah,
there is
yeah.
nothing in Feb. So it will not
Okay.
be a
And
good idea.
okay, ma'am. Ma'am, one another question. If I wanted to join you just to listen your these this as you are discussing the questions in for OSCE, I just
Mm.
wanted to be a listener, not a participant, just listener, and I will prepare myself for the MCPS. But I will listen whenever you have these sessions, so I can pay you for just listening. Just whenever there is any discussion, I will just listen. So it can be okay. Just a listener.
Okay, this is a special case actually, and I
Yeah.
will suggest you to talk me in private. Okay,
Okay,
after the
inshallah. Okay. But ma'am,
session,
please give me answer,
DM.
please.
Oh, why
I am
not?
sending.
Just
Ma'am, you
DM
are
me.
very busy. That is
No.
the reason today I caught you here. Because you are very busy, you don't give me.
So,
Okay,
tell
inshallah.
Dr.
that.
Hira is the only person who always reply. Whenever I text her privately, he always reply.
Really, I am just messaging, texting, but I thought you are very busy. No worry, ma'am. I'll be in contact with you,
Okay,
inshallah.
okay. So the good thing is
Thank you
that
so
in our course, all seats are active. And we are
Okay,
not
ma'am.
actually separately charging for active and passive for this comprehensive course.
Okay,
So
ma'am.
we will make
Okay, ma'am.
sure everyone who will join, she must have to perform. So,
Okay, ma'am.
okay.
I'll talk to you, ma'am.
Okay,
Okay.
okay. So in coming up
Thank
sessions,
you.
once you will subscribe us, there will be a
Yes.
separate sessions as Asra
Mm-hmm.
was asking. Okay, how to do gynecological examination, abdominal, vaginal, or bimanual, and how to do
Mm-hmm.
obstetrical examination, how to do GP, and how to do a targeted exam focused GP. So we will shortly discuss all these things in our coming up session. And here is our pending topic. So, Dr. Asram, are you ready? Ready for this? This will be a very, actually short discussion. Asra and all other candidates, I am hopeful you know primary amenorrhea very well. So this discussion will end within actually 10 minutes. So I know you people are very tired. I will not take more time. So without delay, should we start it? Asra, are you ready?
Yes, doctor.
Okay, so Asra, here is your. Just imagine there when you will appear in your OSCE exam. So there will be yes, one SPT, one long case, and maximum stations you will find they will be structured discussions, and they will be as long as 5 stations. So think about the structure discussion cubicle, and you will see only one examiner sitting there, and there the second person you will be right. And with this arrangement, you will understand this is a SD case. So when you will sit and you actually when you will introduce yourself, you will present your sticker. You will be told to read the scenario, and then you will see this will be written on the task. And now just imagine that you are in that cubicle and read it. You have 10 minutes.
Doctor, there is nothing to read. The slide is not visible.
Okay.
Only the circuit is visible.
Okay, okay. Can you check it now?
Yes. Should I start?
Yes.
Hello, I am Dr. Asra, one of the exam candidate. I have read the instruction ready for the discussion.
Okay. So here is your first question. How you will start this consultation and take history?
Or not, or while using any medication he had bleed or not. Then I would like to ask
Asra, I can't hear you.
any cyclic pain or any mood cyclic mood changes or any urinary retention to rule out the outflow tract obstruction. Then I would like to ask any similar complaints in the family, in the mother or the sister, to rule out the delayed constitutional delay. Or then I would like to ask about any changes in the weight, any gain of weight, any hirsutism, to rule out the polycystic ovarian syndrome, or any change in her weight, that is decrease in the weight, or how about her eating habits, to rule out the anorexia nervosa, or any stress she is have. Then I would like to ask any is she able to differentiate the smell, to rule out the Coleman syndrome. Then any changes and any headache, blurring of vision, or discharge from the nipples, to rule out any pituitary disorder. Then further I would like to ask any history of any history of night sweats, or the night sweats or dryness, so as to rule out any premature ovarian dysfunctioning. Then I would like to ask how whether she was vaccinated or HPV vaccination or not. At any contraception she is using, if she is sexually active. Then further I would like to ask about her medical history, then any chronic medical conditions like chronic kidney disease, or whether she is taking any long-term medications. Then is there is any history of chemotherapy or radiotherapy, antipsychotic drugs she's taking, any allergy to the medications or food. Then I would like to ask any surgery of the any surgery of the tummy or the down below, any blood, what is her blood group, and blood preservations, and any blood transfusion history. Further, I would like to ask about the any family history of concerns, and how about her social habits and social and the social support, and how is her performance at school. Then I would like to examine her in the presence of chaperone after her consent. I would like to look her for for any eye changes, for to rule out the thyroid disease. Then I would like to check her exam any facial hairs and the acne. Then look for the thyroid for any swelling. And I would like to see her the secondary sexual characteristics, that is the
Okay, so Asra, there may be 10 questions, and for each question you are taking 2 minutes.
hematometer.
Can you hear me?
Yes, doctor. Colbus,
So,
then I would like to do the local examination for any ambiguous genitalia, or then for any bulging of the membrane by parting the vulva, and do the rectal examination for the presence of the rectum or uterus
okay,
or not.
okay. So now you yourself will read how it should be an ideal statement. See, so they
Sorry.
said, how will you start this consultation? So you will start, how you will start. Just again read the command. In the first session which I have taken, I told you guys that you are supposed to read the task again and again, at least 2 times, so that you can understand what they are asking. So when you will read it second time, they are actually emphasizing how you will start this consultation with 15-year-old girl. And you will start like this. You yourself are supposed to read. Read loudly.
Examiner, how will you start the consultation and the history? I will
Okay.
introduce myself and confirm the name, age, and explain the purpose of the visit. I will discuss the confidentiality and reserve that and reserve her everything remains private unless there is a risk of harm. I will ask if she prefer to speak alone or trusted on the person accompany here. And then I will take the focus menstrual and the pubertal history. Okay. And I
So
have to
think,
meet in the private. ये doctor, I don't know, मुझे नहीं पता था कि ऐसे भी
it's
है.
okay. So she is 15-year-old, and whenever you will be actually asked to start, how you will start the consultation, it should be that, like this, you will introduce yourself, you will confirm her name and age. It comes, in safety things. And again, you will confirm and explain the purpose of visit. And the best thing actually with this complaint, she can be pregnant, amenorrhea, है ना? So this thing is very important. Confidentiality, like, and she's just 15. And if she want to accompany her with her mother, then what? So you are supposed to actually speak this question as well. Okay. मैं आती हूँ. एक मिनट अस्रा.
Okay. Okay, doctor.
Okay, thank you, Asra, for waiting me.
No problem, doctor.
Okay, so toddlers है ना, फिर ये तो होता है. चलो. Okay, the buzz is that how you will start this consultation, and just imagine she is just 15-year-old. So confidentiality, right? And the second buzz is that you can invite her to accompany someone on whom she can trust. Now towards the routine history points, जो आपने बहुत अच्छे से बताए, right? अच्छा, इसके लिए you can actually make a mnemonic as well. Primary mnemonic, so many DDs हैं, you will lost. So I will give you after the session a mnemonic. You can follow that as well, or you can make your own. But you are supposed to ask everything. Like I will ask about onset, progression of breast and pubic hair development, growth spurt, cyclical pain, systemic clues like headache, galactorrhea. So next. These are the history points. Acha, you will be comfortable if I will give you the template side by side with the questions, or I am supposed to give you everything in the end? Asra, I think it's better
No,
if I
it's
am
okay.
telling the side by side templates. It will be better.
Oh,
So,
Yes,
right.
doctor, it's okay.
So after actually history, in which you are supposed to ask about growth history, cyclical pain history, associated symptoms history, medical history, family history, psychosocial history, sexual history, which you have actually elaborated very well. You just missed about the initial consultation points. History was perfect from my side. But I will suggest to keep it short. It was too long for 10 minutes. So next question. Think she's just 15. Think she's having amenorrhea.
She is just 15, so it could be due to the constitutional delay, or it may be due to maybe she is pregnant.
Okay, so yes, you are right. Safeguarding is very important, apart from confidentiality, right? She is 15, you can ask about that she feels safe or abused or actually forced. And you can ask about specifically sexual activity as well, right? And she's they told you that she is secondary school, you can ask about school environment, she feels safe, any bully there. So these things are specifically should ask for 15-year-old girl. So these are actually table which can make your history more important. Next. Third question. So how you will examine this patient?
I will examine her after taking her consent in the presence of chaperone, and further I will maintain the dignity and the privacy of the patient should be confirmed by me. And then I would examine her on the right side of the by standing on the right side. And I will do her general physical examination, and I would look for specifically I would look in for eyes for any thyroid eye changes for the to rule out the thyroid disease. Then I would like to examine her thyroid for any swelling to rule out again the thyroid disease. Then I would look her secondary sexual characteristics to see whether the breasts are enlarged, the breasts are well developed or not. Then I would look for the pubic axillary hairs. Then I would also examine her abdomen with the inspection. I would like to Dr. Puri batani examination.
You can give me the clues as well from head to toe.
Okay. I would like to, I would examine her abdomen by the inspection, and then I will do the palpation to see any mass in the, for any mass in the abdomen to rule out any urinary retention, or there may be some hematocolpus or mass due to hematocolpus or the hematometra. Then I would like to do the local examination, that is the vulva for any ambiguous genitalia, and the pubic hair distribution, and I will also palpate the inguinal region for any ectopic gonads. And I would apart the vulva to look for any membrane. If it is bluish, then it means that it is imperforate hymen. Or it is pinkish, then it is a transverse vaginal septum. Then I would go for the rectal examination if she is not sexually active to see the presence of the uterus, or if it is sexually active, then I would do the digital examination.
Yes, excellent. This is very important. If she's sexually active, then you will go for PB examination. Otherwise, you will not. Rest, you can read yourself after consent, and in presence of chaperone, you will proceed from head to toe targeted examination, not general physical examination, and rest other things. You said very well: height, weight, BMI, tanner features, staging, thyroid, mass, external genital inspection, and if she is comfortable. If there is, as you told, pink membrane, then it can be like septum. If it is bluish, then it can be imperforate hymen, and you will also see inguinal area for any hernia, like any undescended testes and other things. So this table will help you. Let me, to be very honest, structured discussion is not a difficult task at all. With the proper study material, with us, with your study partner, you can practice it very well. The difficult stations might be in actually majority of cases will be SPTs and long cases, right? So mostly structured discussions go very smooth and straight if you are good in your theory. So let me know if I will ask you what investigations you will plan in this case, what will be that investigations?
Okay, I would like to do the complete blood count for basic health profile, and then I would like to do her beta HCG to rule out the pregnancy, the hormonal profile, that is the follicular stimulating hormone, luteinizing hormone, and thyroid stimulating hormone, and the serum prolactin level, and the serum testosterone level. After that, I would like to review her pelvic scan for the presence of uterus and the ovaries. Then I would, if it is inconclusive, then I may need a MRI for further evaluation. And then I would like to, if there is any suspicion, then I would proceed with the karyotyping as well.
Okay, can you tell me the indications for karyotyping in case of primary amenorrhea?
Yes, the karyotyping I would do if there is a if the uterus is not present, then and the secondary sexual characteristics are there, and the uterus is. I would do the pelvic scan. If there is no uterus, then I would go for the karyotyping, because there are two differential diagnoses. That is it may be the MRKH or the um, androgen sensitivity syndrome to rule out these or the Turner syndrome, which is the most common cause of the primary amenorrhea.
Okay, okay. So, when you will ask about hormonal profile, what are the indications to ask hormonal profile?
The hormonal profiles uh, 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 to rule out the polycystic ovarian syndrome, or to if there is any thyroid abnormality, to rule out that, and if there is any hyperprolactinoma, if to rule out the pituitary cause. That is why I'm going to do the hormonal profile to rule out the causes of the primary amenorrhea.
Okay, so hormonal profile and karyotyping basically also depend on the clinical features as well. If patient is having short height, dysmorphic features, right? So you can directly ask about hormonal profile and karyotyping. They are must in that case. However, stepwise, it will be like that as you told. Uh, 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 urine test for actually fluid pregnancy. If she is sexually active, then scan for uterus and ovaries. Hormonal profile, specifically FSH, LH, prolactin, TSH, with plus minus androgens. If you think on examination, there are a sign of hirsutism as well. So on which day you will ask this hormonal profile? She is having actually amenorrhea. Any day?
Mm. Yeah,
Yes, any day.
doctor, it could be
No,
any.
no, any day. Okay. So if she's having secondary amenorrhea or she's having cycle, then day 3, right? Okay, so karyotype depends on scan and on hormonal profile, right? On scan, if they said uterus is not present, but ovaries are present, and then it is MRKH, and you will confirm it on karyotype. And if on scan they said no uterus and no ovaries, then it's AIS, then you will again confirm it on karyotyping. And apart from these things, ultrasound things, if on hormonal profile you think FSH is too high, she is having ovarian failure, then it's another indication to ask karyotype, right? Which you can see in internal mosaics and early ovarian failures. And last one will be the MRI. So, what will be the sequence of asking these investigations? First, you will ask karyotype, or first you will ask MRI? It's very important.
First, I will ask MRI.
Why? Just tell me the correct sequence. Okay, you will ask pelvic scan, then you will ask hormonal profile, then you will ask karyotype. In karyotype, it is XX, then it is MRKH. And for MRKH, you have to actually confirm the type of anomaly to confirm that it is really MRKH or not, right? And any associated renal issues, then you will go for MRI, but after karyotype. This is the biggest mistake which actually majority of candidates do. They ask it after asking the after the pelvic scan. So I will suggest you ask it after the karyotype, right? And don't ask every investigation. You are supposed to say that I will ask karyotype, and karyotype depends on scan, not straightforward without asking the result for scan. So, and it can change it. See, if on scan there is a hematocolpus, will you ask about karyotype?
No.
So it's very important. The next investigation depends on the previous investigation result. So it's table. This is the table which can help you. The next question. Our examination. What are your differentials in this case?
My differential diagnosis is, it may be due to the it could be due to the constitutional delay, or or it may be due to an anatomical defect, that is the might be due to an anatomical defect in the form of imperforated hymen, or or maybe some hormonal disturbance, like any thyroid disorder, or and any PCO, or then it could be due to some it may be due to some chromosomal defect, like the Mullerian agenesis, or androgen sensitivity syndrome, or it could be due to some Turner syndrome or the hypothalamic hypogonadotrophic hypogonadism, like Coleman syndrome, and
Okay, right.
all should
So
be
if
depend
examiner
upon
is
the
giving you investigation results, then you will plan your differentials wisely. And according to the investigations, you will actually prioritize what will be the first, what will be the second, what will be the third. If examiner is not giving you any investigation result right now, then you will enlist all your differentials as you have told me. Physiological delay, outflow obstruction, Turner, Kalaman, MRKH, AIS, right? And you don't know about actually examination findings. If they have not mentioned there is hirsutism or not, then it can be CH as well. So you will actually answer like all main differentials. But if you will be provided with some clues that she is having breast, no hirsutism, then you will be stick to the top three, like MRKH, AIS, or ovarian failure. Then you will not actually explain everything which will come in differential, right? So if examiner will say you, okay, right, on examination she is having secondary sexual features, on scan her uterus is absent, on karyotype her result is she's having 46 XX result, and on MRI it is confirmed that she is having MRKH with renal agenesis. So what will be your diagnosis now? Matlab, now you are having all your required labs.
Okay, my diagnosis is MRKA. That is, I will counsel the patient. I will counsel the patient in a very empathetic way that she is having a problem, which occur in every 1 in 5,000 of the female, in which they have ovaries, but no uterus, no uterus. So I will provide her support group, and provide a support group, and then I will also counsel her that she can be made sexually active by the management, like dilators, simple dilators, or there may be the vaginoplasty is also an option. And for the fertility prospect, I would also counsel her that as she has the ovaries, the eggs are there, so that she has the option of surrogacy or uterine implantation, and last option is the adoption.
Okay, so
Further, I will also
but examiner command was only that how you will identify the MRKH, and you are telling me the management and whole management till surgical and non-surgical. So this is actually common mistake. Again, I will advise you read the command 2 times so that you can understand what they're asking. You are supposed to tell what they're asking, not what you know actually. So इतना चुनना सा इसका आंसर था. ठीक है, normal breast, pubic hair with absent uterus, upper vagina on ultrasound, normal ovaries, karyotype 46 SS. This is consistent with MRKH syndrome. That's it. And the next question will be that how you will manage MRKH. And you perfectly said that I will approach. No, you didn't say that I will approach empathetically. You forget it, and it's very important that you will approach her empathetically, ensure her privacy, and offer someone to accompany her when you are discussing with her management. See, she's just 15 years. So here again, risk management will come. She can't understand everything, right? Just think about the Gillick competency. And Gillick competency is not only about the contraception and everything, it's about that how actually better minor can understand and absorb the information and reproduce them. That's why. If she's 15, you can offer her someone to accompany her here in management as well. Then you will say that I will explain that it's a congenital condition where uterus and part of vagina didn't form, but ovaries and hormones are normal. And I will reassure her, and it's very important to say that I will reassure her that she can live a healthy life with normal sexual function, right? And then you will actually, there will be a lot of gossips how we'll create a functional vagina, and then you will say that again, you will reassure her that she is completely female with normal hormones. Thank her for her trust, explain treatment options, and arrange follow-up with specialist team for long-term care. And then you will discuss non-surgical and surgical, and you can read it very well. Now it's just a theoretical part, and you will have these slides as well. So main thing in this structured discussion was that, and the main buzz was that she is just 15. And you have to modify this case. Actually considering a lot of things, safeguarding confidentiality, abuse, right? Consent issues. So what about ongoing sport? And again, this is a MDD work and a long-term follow-up. And fertility options, this is very important. How you will advise regarding her fertility if she want to be a mom in future?
Yes, the fertility options for her, as she's having fortunately she's having have a ovaries, so she can have her own eggs. And the fertility options for her is the surrogacy, that is with her eggs and her husband sperm. She can have an option of surrogacy, or there is an option of uterine transplantation as well, and the last option is adoption.
Okay.
Uterine
Avoid using
transplant का बताना
husband
है या
term.
फिर-
No, don't avoid using husband term. Avoid using instead of husband, use partner term. Right? Rest you are right. Ovaries are normal. She can produce eggs, so we can offer her gestational surrogacy. And when you are saying about uterine transplant, then actually mention with it. It's not a routine. It's in research yet and done only in specialized centers. And third thing will be adoption. So you will provide her actually reproductive counseling and emotional support, and refer her for counseling as well if you think she is not emotionally well. And that's it. Hmm? So if you want to
Okay.
read it in detail, I will provide you detailed slides which you can access on portal as well. So he had the word script which you are supposed to actually cram. And this station can come in SPT as well. She can be a role player with a lab, with karyotype, with scan, showing that she is having MRKH, and you have to proceed the way Dr. Saba told you. So you can modify the same station in SPT station as well.
Okay, doctor.
So this is experimental and limited availability. Okay, and long-term follow-up. So here we are going to end it. Apology for taking too much time. So in the beginning, we will take few time for SDs and SPTs and long cases. Once you will be in flow, then you will think we are actually covering up 6 stations in a session only in 2 to 3 hours. So don't be overwhelmed. Okay, so thank you everyone, and see you people in course now. Asra, you perform very well. I know this was your first SDs, and it was my own first SD as a mentor as well. So together we will learn a lot. There are only silly actually mistakes which you can easily improve, right?
थैंक यू सो मच डॉक्टर, आपकी पुरानी चीजें निकाल के बैठी हुई थी। मुझे यही कंफ्यूजन थी, ये कुछ अजीब सा कि एफसीपीएस से मिला जुला बिल्कुल लग रहा है,
यार अब
लॉन्ग
एफसीपीएस
केस बिल्कुल
नहीं, एफसीपीएस जैसा ही है, सिर्फ आपको मैं मसाले लगाने थे, कॉन्फिडेंशियलिटी, सेफगार्डिंग, अब्यूज। तो थोड़ी बहुत ये, हाँ, पार्टनर, हस्बैंड के टाइप पार्टनर आ गया, 2-4 चीजें चेंज कर दी है माइंडसेट में, बाकी सब चीजें वैसी हैं जैसे एफसीपीएस में था। ठीक है,
जी जी, मैं वही निकाल के सारी चीजें आपकी बैठी हुई थी, क्या क्या है उसमें से जो पड़ा था आपका सारा
okay.
मटेरियल।
So I
थैंक यू
have
डॉक्टर।
okay, so I have planned I will take STs only, and the way you will be comfortable depend audience. If you can understand only English, then we will talk only in English. But in my sessions, I will be more comfortable with mixed language if the audience will can understand both languages. So we will actually see. And thank you everyone. Okay, enough is.